Good morning and welcome, everybody. I'm calling the 448th Council meeting to order. Welcome. Thank you for joining us today in person, as well as joining us virtually. A reminder, Council members, to please have your video on during the meeting and to mute yourself when you are not speaking. And to all, we are live streaming this meeting through the RCDSO's YouTube channel so that members of the public, profession, and other interested parties can watch our proceedings. Quick reminder to use your Zoom hands, please, when voting, for questions and for comments. And at this point in time, I would like to turn to the official land acknowledgement for our meeting. The RCDSO is on the traditional lands of the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Huron-Wendat peoples. These traditional lands are known to some as Toronto. Toronto is covered by Treaty 13 with the Mississaugas of the Credit and is home to many diverse First Nations, Inuit, and Métis people from across Turtle Island. This land is also part of the Dish with One Spoon territory, a treaty between allied nations to peaceably share and care for this land. We accept our responsibility to each other and this land we live and work on in a spirit of peace, friendship, and respect. We are committed to actively supporting the necessary work towards truth, reconciliation, and equity. We embrace the role we play in regulating dentists, in protecting the public interest, and in strengthening our partnerships with Indigenous communities to advance access to safe and equitable oral health care. Thank you. And now, as we begin the formal part of our meeting, I would just like to highlight the importance of a great meeting culture. We had an excellent education session in February where we received great advice on how to improve conversations. This is a high-functioning council where standards of contribution are exemplary. Your engagement, the participation of all of you, is critical to the functioning of the college. Your guidance has impact. With such a large group, there will always be limitations to how much time we can spend, but we endeavor to make time for the items that need your deeper input. Items that are early in development need more of a conversation. In some cases, there will be matters coming before you that have come across this table a number of times. These matters can be dealt with more quickly. This distinction will allow for confidence in our process. My role will be both to help manage the agenda and the speakers list, but also help facilitate conversations where it makes sense. We are very open to hearing how well this works for you as we work to optimize our time together. As ever, we are gathered here to protect the public interest and to do that through active, engaged governance. I will do my very best to help you do that every time that we meet. And at this point in time, I'm going to turn it over to Dan to do a roll call. Dan?
Thank you, Hanno. Good morning, Council. If you are joining us virtually, please be ready to unmute. And if you're in the room, please turn on your mic. So I'll start the roll call. Nalam Bhargava.
Present.
Ram Chopra.
Present.
Jamie Colliver.
Present.
Christina Cordero.
Present.
Peter Delane. Present. Ellie Fisher.
Present.
Daniel Fortino.
Present.
Neil Gajar.
Present.
Noha Goma. I think Noha will be joining us today. She's not here yet. Daniel Haas.
Present.
Iliad Horner-Parvar.
Present.
Vivian Hu.
Present.
Nizar Ladak.
Present.
Anthony Licio.
Present.
Anthony Mayer.
Present.
Harinder Sandhu.
Present.
Brian Smith.
Present.
Usama Solomon.
Present.
Robin Somerville.
Present.
Rod Stapleforth. Rod has sent his regrets. Mark Trudell.
Present.
Aaron Walker.
Present.
Judy Welikovich.
Present.
And Deborah Wilson.
Present.
Thank you, Hanno. Back to you.
Thank you. I'll now ask Dr. Harinder Sandhu to provide the President's remarks. Harinder, please.
Good morning, everyone. I'm very happy to see you all in this room and online. Welcome again to our new council members, Dr. Gajar, Dr. Fantino, and Dr. Honor Paravar. You have hit the ground running. You're doing your research. Your contributions will enhance the conversation we have at this table. While on the subject of council members, I would like to congratulate Dr. Noha Goma. Dr. Goma was just elected as Vice President at the Canadian Association for Dental Research. Congratulations. Let's give her a clap. Our colleague, council member Nizar Ladakh has published a book. It comes out in July and is called The Power of Scars, My Journey from Refugee to CEO. It is available on pre-order for your local bookstores. Congratulations to Nazar. Give her a thanks. Council, we have an incredible day ahead of us. For those of us who have been here for a few years, we saw all the work that went into the development of the 23-25 strategic plan. We knew then that it was ambitious and that the work had the potential to be transformative to the profession. As a council, we recommended that additional staff with policy expertise be brought on to do this work. We knew it was important. Today, we are about to see a number of key projects come to fruition. Personally, I'm very proud of the extraordinary work done under this plan. You have been part of this work all along. You read the regular reports in our council materials. Many of you sit on working groups to help this work advance. You have heard about this work as it progresses. Some of you have participated in consultations. So thank you for your part in guiding these projects so far. Today, we will hear about two new standards of practice: consent to treatment and prevention of sexual abuse and boundary violations. We will hear about the foundations of professionalism document. We will learn about our developing work on artificial intelligence in practice. And we will understand more about how we can help ensure effective regulation regardless of whether a dentist practices alone or as a part of a large corporation. Council, we will hear more. There are more standards making their way to the table. We'll be making more progress in AI and on access to care. We have an exciting year ahead of us. None of this would have happened without the RCDSO staff. I know you join me in acknowledging the incredible work they are doing on the strategic plan. Please give them a big hand. Colleagues, we continue to work closely and collaboratively with the Ontario Dental Association. The RCDSO will have a booth at the upcoming annual spring meeting, which is the largest gathering of the association members. A number of college dentists will be providing educational sessions to ODA members at the convention. We are happy to have the opportunity to provide the profession with resources and education. We are discussing the possibility of collaboration with the ODA to conduct a survey of dentists. This could help us to better understand the dental hygiene labor issues in dental practices, and this in turn may impact access to care. Hanno mentioned it earlier, but I was very inspired by our education session in February. We learned a great deal about having productive meetings and great conversations. It's a privilege to learn and work alongside all of you. Finally, I would like to thank those who helped prepare this meeting. Much of this work is behind the scenes, from developing hundreds of pages of material to the complex coordination of this hybrid meeting. It is a lot of work. Thank you to the college staff. We would not be able to govern without your support. Dan, thank you for all that you do for me and for this council. Your senior leadership team and the entire staff of RCDSO help us do our jobs. Council, thank you in advance for your contribution today. I know we have a lot to do today. Your thoughtful advice is so important. As always, there are a number of people who join us via YouTube. Thank you so much for your interest in the college. With that, Hano, I'll turn it back to you.
Thank you, Harinder. Next on the agenda is declaration of conflict of interest. Declaration of conflicts is a standard that is captured in the Ministry of Health College Performance Measurement Framework, and a reminder, Council, that the college is working with PricewaterhouseCoopers on the PLP divestment project. At this point in time, I will ask if any members of Council feel that they have a conflict of interest, real or perceived, to declare for any of the agenda items to be discussed today. And I'm seeing none. Thank you. Our next item on the agenda is the consent agenda. As a governance best practice, we use the consent agenda as a time-saving mechanism. On the consent agenda are several items that are for Council's information, acceptance, and ratification. Council will be asked to approve these in one single motion. Council, you may ask clarification questions about an item on the consent agenda. If members wish to have a conversation about an item, we will take it out of the consent agenda and address it later on in our meeting. I would ask, if you do so, that you use a very high bar when asking to remove an item from the consent agenda. The items for the consent agenda are in your meeting package from pages 14 to 102. Are there any questions about any of the items on the consent agenda? Seeing none, could I have the first motion on the screen, please? And the first motion is that the following items be approved and or received for information by Council. Approval of agenda, approval of RCDSO Council meeting minutes, January 23rd, 2025, Council evaluation survey results, January 23, 2025, Registrar and CEO report, RCDSO Council work plan 2025, financial update, RCDSO strategic plan 2023 to 2025, and policy report. And if I could have a mover, please, Anthony Lisho, seconded by Aaron Walker. All those in favor, please raise your virtual hand. And that is carried. Thank you. Council, you have a report in your package from the Registrar and CEO, and at this point in time, I'm going to turn it over to you, Dan, to walk us through your report, please.
Thank you, Hanno, and good morning, Council. It's my pleasure to present to you the report of a lot of the work that's happening at the college. You have my written report. I'm not going to go over everything that's in it, but I'm happy to take any questions. What I wanted to do in the next few minutes is just take you through a short slide deck with a few key points that I wanted to bring to Council's attention. Next slide, please. I often start by looking across the environment, whether that's Canada or globally, in terms of what's happening with respect to regulation and governance. A couple of issues that I raised in my report. There was a Bill 36 that was introduced in the Nova Scotia legislature a few weeks ago, and that bill is all part of the, I think you fell out, sorry. I was just getting some feedback. That bill was part of provincial directions to support movement across the country of goods, services, and professions, those who have licensure or certification. One of the things that was raised by the health colleges in Nova Scotia was that it seemed to allow healthcare professionals to move into Nova Scotia without any sort of contact with the regulatory body within that jurisdiction. Also not allowing necessarily for any checks on the standing or the certificate of standing of those individuals. The intent of the legislation was obviously very positive in terms of allowing for barriers to be removed, but it also had some unintended consequences. Subsequently, the health regulatory bodies did work with their provincial government, and I understand that some changes are in the works that will at least allow for individuals to, authorize or obligate individuals to communicate with the regulatory body, and for the regulatory body to, if not apply new assessments because they are licensed in another Canadian jurisdiction, at least be able to look at their certificate of standing that is available from another province or territory. So some of those amendments are still playing out. Next slide, please. And I think what one of the big messages for us as a college and in Ontario is that we're going to start seeing, I'm quite certain, legislation and different ways in which to continue to promote interprovincial mobility of healthcare professionals and many other things. You'll recall that back in 2023, the Ontario legislature passed a bill, the As of Right legislation, as it was called. It included many things, but one part was to enable members of certain health professions to come to Ontario and to practice without having necessarily to be licensed by the regulatory body. It applied only at that point and still to 4 professions: medicine, nursing, medical laboratory technologists, and respiratory therapists. And there were regulations that were put into place. Those 4 colleges were able to develop with the government regulations that allowed for certain provisions to be implemented that would ensure patient safety. But this is the sort of legislation that we may see expand. We may see other components that are developed that continue to really push for more mobility interprovincially. And what we will always do is make sure that patient safety and public safety is first and foremost. But I do also want to inform council, and I'm sure all of you know this already, and one thing that we will continue to message to the government is that we do already license more internationally trained dentists. We have very fast processes, so once we have a completed application, whether you're an internationally trained dentist or coming from another jurisdiction, we can turn around your approval very quickly, less than 5 days for the most part. And we also continue to provide leadership as a college to our national bodies and working with them, and I'll talk in a moment about some of that work, to really ensure that barriers continue to be removed for internationally trained and now our latest priority, which is the mobility across the country. Next slide. I want to just mention that we're working also with a number of partners. We work with partners and collaborators every single day, provincially and nationally. A couple of notes related to requests that we've received lately. I've talked at this table, and our president has talked in a number of different ways about really trying to understand our health human resources state. And that means the supply that's available, and it could be dentists or it could be other oral healthcare professionals. And also, how do we understand the demand, and how do we, as a college, contribute to some of those studies? We can't do health human resource planning, but we can, in some small ways, contribute to that work that will be done by others. We've been approached within the last few months by the Canadian Health Workforce Network and also by CIHI, the Canadian Institute for Health Information, to talk about providing the provision of data from our register that will help to truly understand not just the numbers, but as you know, the dentists around the table, we collect a lot of information about what you do in practice. And that's really a jewel that we have in terms of understanding how much of your time is contributing to clinical practice and patient care, and how much might be available to other endeavors like research or administration or teaching or community work. And that kind of data is really going to be helpful going forward. So we're working right now and talking to CIHI and CHWN about how we might meaningfully contribute data from the public register with responsible data sharing agreements if we get to that point. But this will certainly support some of the health human resource planning that we need in this country and in this province, and we're prepared to do our small part to support that. I've also mentioned that last year we submitted to the Oral Health Access Fund for the potential to fund a project that would look at supporting internationally trained dentists in Canada, in Ontario, who might work under some supervised practice setting in areas where there's an access to care issue, and really trying to support capacity within certain environments as well. We did submit a proposal. Unfortunately, we weren't one of the groups that was asked to submit a full proposal, but we are actually turning that proposal around and having some conversations with the provincial government and seeing if there's an opportunity to secure some funding for either that project or some portion of that project that we might be able to really help to support a number of key priorities for this college. So I will keep you informed of that as we move forward. Next slide. Really quickly, there's been a number of reports that come out from Statistics Canada. I get them regularly, and some of you may get them as well, and I'll try to provide those to council as they're received. But you can see in the last 6 or 7 months, there's been a number of reports that relate to oral health care. The most recent one came across my email yesterday, which was a survey results of oral health care providers. And you can see, and I haven't had a chance to really dive into it deeply, so I couldn't answer a lot of questions about it, but some of the highlights that they wrote as their key messages were that 80% of oral health practices face human resource challenges. 96% of oral health care practices are accepting new patients. And over the next 2 years, and thinking about, again, the supply issue, just under 60% are planning to maintain their current operations at the level that they're at, and about 31% plan to expand. So this gives us some really good insight as a system in terms of oral health care and dentists' role within that. Other reports related to patients in the public and cost-related avoidance of oral health services, where they found that 24% of the respondents avoided the dentist in the last 12 months due to cost. I don't think this is any new information to you, but again, supports a lot of the work that you'll hear about today and that we're doing as a college as well. So you'll see the other reports, and you'll have this slide deck. But we can certainly make sure that you get a copy of these reports if you're interested in reading them and jumping a bit more deeply into the results. Next slide. And finally, we work with all of our national partners, whether it's the examining body or the accreditation body. Recently, the Association of Canadian Faculties of Dentistry, through grant funding from the Foreign Credentials Recognition Program, have developed a project. This is a multi-year project to look at an additional pathway to licensure for internationally trained dentists. So without a lot of detail, there are currently 2 pathways, one where you write a number of examinations through the National Dental Examining Board, the second where you go back for a degree qualifying program, and this third project is related to whether there's the ability to assess an individual who has arrived from an unaccredited school from another jurisdiction internationally. Can the universities and through their faculty assess individuals to understand if they are close to the standard of practice in Canada, and can they provide then education? I call it top-up education. It's just some education that will allow them within 8 months, and that's the sort of cutoff maximum, within 8 months to be at the Canadian standard to be able to challenge the NDEB certification exam. So this is in development. This is a first cohort. There will be 2 years of pilot studies with evaluation. And I want to emphasize, this is not about reducing or changing the standard. It's about measuring it in a different way. and being able to assure the licensing bodies that the individual has met the standard and has passed their certification exam and is able then to be licensed if that's the pathway. So it will add an additional pathway, which is something that we've worked very hard with our national partners to do, and we're very involved directly in the development of this project, as are many of the other players that I've mentioned already. Next slide. I'm going to round out by talking a little bit about some things that are happening around the college that you might not normally receive at this table. Next slide. You have the corporate dashboard report. We provide this on a regular basis to council to give you an indication over several meetings of data that we look at and ensure that all of our leaders are paying attention to this within their program areas. I've put 3 in slides just to point out and remind you of some of the really great work that's happening around the college. The first relates to registration. And these are average application decision timelines. So the ability to approve applications when they are received in a completed form. The legislative requirement is to do so within 30 days. That's the dashed line at the top. And we're doing it consistently over many months in 5 days or less. So that's a really strong message to be sending in terms of we're not a barrier. We are, when we have the information, able to license individuals quickly. So our partnership work with others and our work at the college, I think, combined, really help to show the college as a solution-oriented organization. Next slide. Our facilities inspection program is also working very hard to really deal with some of the backlog. You can see that over several years, there have been a number of CT facility permit applications that have been opened. So we are obviously taking those that are the furthest back from 2022 and 2023 and trying to really ensure that we get decisions made on each of those applications. Our 2022 application population is now at 0. We're working hard on 2023 and 2024. And you can see the yellow line of 2024, it has gone up and obviously has stopped, but we'll be pushing those through to really reduce the timelines and also to ensure that the backlog is addressed. So some more work to do, but some very positive results already in terms of managing that particular backlog. And finally, next slide. I want to just show you a slide. You've heard from me many times and from Jill Slaughter about the work, the amazing work that's being done in our PCRA department to really, over the last 4 years, deal with the backlog of cases that were there, the timelines. What I want you to take from this slide is the top 2 red bars are the cases that are over 300 days. So sometimes there's a very good reason for a case to go on for a long time. It's a very complex case. It involves very complex investigative processes. But what we are doing is reducing those cases that are over that period of time and also striving to ensure that most of the cases fall in the three other colors below it, so that we're looking at cases that we can do by and large within 150 days. But when we go over and when we have reporting obligations back to the parties, whether it's the dentist or the complainant, we will continue to do so. But the goal is not to have too many that are beyond 300 days. And we'll continue to show this graph to you as we move forward. Next slide. Briefly, I just want to mention to you that we are in March, and March 31st is the day in which we submit our annual report to the ministry on the College Performance Measurement Framework, CPMF. For those who are new to council, this is a mandatory report that we must submit. It cuts across several domains of what regulators do. It has a number of standards that we must fulfill. We are on the cusp of submitting it. I have a final draft that I'll be looking at tomorrow, and it will go in by Monday. What I want to say to council is that last year we met almost every standard, and 2 we partially met. This year we meet all the standards. So obviously it wasn't expected that in the first couple of years of this, I think this is the 4th year, it wasn't expected that we would meet every standard. All 26 colleges have to do this, but we were given an opportunity to ensure that we made improvements where improvements were necessary, and we have done so as a college. This report is extensive. It sometimes reaches 100 pages, but we provide a summary as well, and I've put sort of a picture of the summary report that we provided last year to show some of our trending over the first 4 years of providing this report. So it's all online, it's all transparent to the general public, and you can certainly have a copy next week as well. Next slide. Some really exciting work. We've made a real commitment internally to staff in terms of understanding how things are going for them, how they feel about the work experience working at the college. We have conducted a number of surveys of staff to really understand what it means to work at the college for them. This year, or in the fall 2024, we conducted our biannual survey every 2 years, and we used an external organization, Mercer, because they have a number of standardized questions that worked for us. We were allowed to customize some of the questions, and we also have a comparator now across many hundreds of organizations and thousands or tens of thousands of employees. So those comparators are really important just to see where we land. I'm not going to provide you with all the data, but I wanted to just state that of all the questions that we had within our survey, we now have this incredible opportunity to slice that data in a number of different ways. We can look at departments, we can look across the demographics of the organization, we can look across the various staff roles, whether it's a frontline position, whether it's a leadership position, and really try to understand what's working globally and what's working within smaller areas. So we've been looking at that with our staff. We've provided this information to all of our staff, and we've provided it to our leadership team, and we've been working a lot with our leadership team to really draw out the themes, plan actions, and be able to remeasure down the road. So we'll be conducting some pulse surveys as we go through this year, and we'll do our big survey in the fall of 2026. So our commitment is to continue to understand the employee experience. So if I could have the next slide, just to give you a real quick glimpse without a lot of data. As I said, or as I had in the slide, we had a 91% response rate. So we had 129 staff who responded, which is incredible. We have a really strong understanding now of the information that's been provided. What's working well? Staff told us that the flex work environment that we have and the tools that are available to work, whether they're remote or whether they come into the office, are working. Respect for staff by leaders is there. That's really important to me and to the leadership team. The staff member said that my role aligns with the goals and the strategic direction of the organization. I want to just stop there for a moment. That's something that every organization strives to do. You always want to try to ensure that staff really understand that their role, no matter what it is, has a contribution back to the goals of the organization. And 90 or 91% of our staff said that they could see how their role fit within that. So that's a really positive result. We have well-defined processes in some of our areas like FIP and PCRA, and there's great pride in working at the college. Some areas that we can improve on, because there are always areas that we can improve on. Communication across the departments. We worked hard over the last couple of years to try to improve that. There's still some more work to do and to make sure that that happens at a level that's better understood and better seen. More engagement with the senior team. The senior team has had a lot of engagement with our broader leadership group, directors, managers, supervisors, but clearly there's some more work that we want to do to make sure that there's more engagement across the entire organization. Conditions created that will help to promote idea generation and sharing so that we get the best out of our staff. Everyone has lots of different ideas to bring to their role and to the organization, and we want to tap into that as much as possible. Fair compensation and rewards for performance. This is something that I'm sure is felt by many organizations in the climate that we're in, that there might be a sense that the compensation is not necessarily at a level that anyone wants, and are we rewarding appropriately for high performance? And this is something that the senior team is already starting to look at and considering what's possible within the responsible approach that we take to performance management and compensation compensation systems, and more diversity at all levels of the college. You've heard a lot of commentary at this table from many different topics and from many different staff about the commitment that we have to equity, diversity, inclusion, and the work on the ground that we're doing to really try to promote that. So that's something that we will continue to focus on as well. So very pleased with those results, and I'll round out with another really positive story. On the left is, this is our branding, RCDSO Connect, around our communication and engagement with not just the profession, but also the public and also other partners and stakeholder groups. On the left is the newsletter that just went out. I hope you all received it. It's chock full of information, really great information that you can link to and read some more information about certain topics, lots of really timely topics. On the right is just a screenshot of RCDSO Connect, which is the webinar opportunity that we provide to the profession. And next slide. I want to give you some of the data that we've had, which is just incredible. We've had 3 events recently. So within last fall, February, and March of this year. So antibiotic overuse was presented last fall. Quantifying disability and providing a case complexity tool that would help individuals manage with and form relationships with patients who require sometimes some different ways in which the oral health care experience is delivered, and also on artificial intelligence. So look at the numbers in terms of attendance, and we've been really working to build out the capacity of our webinar system. 577 attended in November, 807 attended in February, over 1,300 attended in March, and we have 2,400 signed up for next week. Generally, we'll get more signups than those who actually attend, but it's probably in the neighborhood of 80% or so who will sign on the day of the event. Those numbers are really incredible. One of the goals that we have as an organization is transparency, engagement, and communication with the profession, but also with our other stakeholders. This is really looking at the profession and providing timely, relevant, practical information to them on a regular basis. We've also incorporated an education points model for some of these events, not all, but some of them where there is a real learning opportunity. And you can see that over these 3 events, we have issued over 2,700 Category 1 certificates for 1 point, I believe. And then if you watch the event after the fact on YouTube, we've had over 300. I'm sorry, no, this is a different, there's another stat for the YouTube watching. But we've had over 313 who've received Category 2 points for implementing the tools. Which is, again, what we want. We don't just want people to sit and listen. We want them to take what they've learned and implement it in their practice. And so we're trying to incentivize it, and we're also trying to ensure that this is widely available to the profession. So lots of real positive results that we'll continue to report on back to this group. Next slide. So that's a lot, but there's a lot more that's going around in the college, and I'll stop there. I'm happy to take any questions about the report that's in the package or about anything that I've presented today. Thank you, Hannah.
Thank you, Dan. At this point in time, Council, we do have a few moments, or a few minutes rather. If there are any people who have questions, Jamie Colliver.
Yeah, thanks for that report, Dan. 2 questions. The 8-month period that you referred to, is that a college? Is that a college timeframe?
So, Jamie, you're talking about the
qualification.
bridge,
The bridging.
bridge training program. That is a time frame that's been developed through the project development where regulators have contributed. So I sit on the steering committee. The Federation of Regulators sits on the steering committee, and there's one other whom I'm forgetting. So regulators are involved in that, and the reason that it's 8 months, and I'm not sure if you're asking because you think it's low, but the reason that it's 8 months is because these are individuals who have an assessment to determine where they are within the standards that are expected of Canadian graduates. And so it's trying to look for those who are very close to the standard and trying to develop that alternative pathway. and then after the assessment, apply up to 8 months of training that's related to them, almost customized to their particular needs.
Yeah, the
Did I
reason
hit
for
on the
Yeah, you
question?
certainly did, and, you know, it'd be awesome if we could even shorten that period, given the constraints within the profession.
I'll take that under advisement. I know there's a lot of discussion about that, and 8 months, I think, is going to be tight.
Is it? Okay.
But absolutely, I'll take that.
And my second question was regarding the, it sounded like it was very much a qualitative connection to staff with regards to understanding their roles and the ability to speak up, et cetera, et cetera. Is there a collection of data as part of that? And is there a measurement of staff efficiency based on the collection of data?
So there's not a measurement on staff efficiency. This was a staff experience survey. There's a lot of data. I've given you themes and a little snapshot of data. There are 60-plus questions that are quantitative. And it's trying to understand whether, in response to a particular question, does the staff member have a favorable response to that question or that particular theme. So a lot of data, quantitative data, and a number of comments. So we didn't have a lot of areas for comments, but it was more of the quantitative approach, and then what's working really well and what's one thing that you would improve if you could at the college. So we've got a ton of data that the leadership team is still pouring through.
Thank you. Anthony Lisho? Okay, Anthony, you are muted right now.
Yes, thank you very much for pointing that out. Dan, have you heard anything at all from government with regard to staff, for example, level 1 or level 2, in terms of that component of the office, of the dental office caregivers to be regulated?
So personally, I have not had a lot of discussions about that. Obviously, the provincial government has been in a shutdown mode for the last election period. That is something, though, that the association is actively working on and having more conversations with the government. I think, we try to be very cautious in terms of where we are positioning ourselves with government and with respect to other professions. This is something that there have been conversations that have related to it, but we're not actively exploring the numbers or the particular profession, the dental assistants that you mentioned. But I know that there is a lot of work that's happening through the association.
Thank you. Mark Trudell?
I think Osama had.
Thanks, Hanno. Dan, thank you for the report. Comprehensive as always, thank you. Just touching on the CPMF, and the topic is governance. As we enter another round of strategic planning, I wonder if you can share with Council your thoughts with regards to some of the takeaways from the most recent CPMF analysis review annual, and where there might be a dotted line or a solid line over to our strategic planning process. Metrics that we're taking away in the most recent round that we might want to reflect in our strategic plan upcoming.
I would say that in the governance domain, we have probably been ahead of the curve on the CPMF standards for quite some time. The CPMF standards approach issues like competency-based boards. They don't necessarily go to competency-based elections, but that's something that obviously this college has implemented for at least the last 2 election cycles, if not 3. So we've been ahead of the curve on all of the standards in governance, and we continue to improve. I guess I don't know how to answer your question specifically, But some of the areas that we've heard talked about at government that have come to this table, they haven't come in a while, but relate to governance and may relate to strategy, might be issues like smaller boards, might be issues like amalgamations of health colleges. That is not something that the government has raised in some time. But if you think back to the letter that this college received from the provincial government in early 2022, we have probably done as much as we can pushing up against the legislative restrictions that we currently have. And so perhaps the connection to strategy would be, what do we want to influence next? And where we will take that. And that'll be, I'm sure, a discussion that will occur as we head into our June strategic session.
Thank you. Osama, did you have a question? Okay, so last person on my speakers list is Ram.
Dan, you mentioned, sorry. You mentioned about new foreign trained Canadian dentists to be trained in certain ways. Has there been any communication with the government of Ontario, whether they will be able to open the emergency class of, to register those?
That's not something that I'm hearing. And for those who are new around the table, this college, as did every one of the 26 health colleges, approved an emergency class license or certificate of registration last year, or I guess we're almost a year and a half now. It's not something, Ram, that I'm hearing in terms of opening up that class. And I'm not so sure we really understand what numbers we need. And I'm certainly not hearing that there's a shortage of dentists. I think it depends on who you're talking to and what they say. So the short answer, simple answer to your question is no. There's been no discussion about opening that class. I'm not aware of that class being open for any health college in Ontario.
Okay, thank you.
Thank you. And now the last speaker on my list is Daniel Fortino.
Sorry, just one question, Dan, regarding the bridge program. This may be redundant, but can you provide some assessment tools that we're using in that bridge program to ensure that the qualifications are met from internationally trained dentists? Just quickly to run through some of those.
So I can give you a glimpse, and one thing that we are doing is next week at our executive committee meeting, we are going to, for those on exec, have one of the leads of that project present more specifics in terms of the assessment and the education that's being used, and we can certainly bring that to council as well. But they are using a combination of some of the exams that are currently provided by the NDEB, like the first exam that assesses knowledge and the second exam that assesses judgment. So those will be precursors. Those will be criteria to get into the program. And then they will use some other assessments within the university faculty that will allow them to understand some other aspects of practice that you might not get through those particular examinations. The education that's being provided, some of it's being developed fresh, it's new. It's going to relate to the non-clinical skills, the things that relate to working in a team, communication. There will be patient care, direct patient care provided by individuals. So they're really trying to develop a robust model that will understand the individuals that are trying to go through this program. And I want council to keep in mind that we talk about, internationally trained dentists as if they're a homogeneous group. They're not. There's a wide variety of training around the world, and they all fall into this one category and have different streams. So this is a way to try to address the fact that some will bring a lot more experience and knowledge and skills closer to the Canadian standard than others will.
Thank you. Council, I'd like to move on to the next item on the agenda, please, which is item number 7. You will recall that at our October meeting, we heard about the research that has been done on practice models and corporate dentistry. This is an item that we were scheduled to discuss at our December meeting, but we were not able to do so, so it is coming before you now. Today, we will see how that research has informed the development of several options: The options you will hear about are designed to promote and assure quality of care and ensure effective regulation of dentists, regardless of practice model types. The materials for this item are on pages 103 to 127 of your meeting package, and this matter is for information and discussion. I want to remind Council that as per our discussion on effective meetings, this is an item that does not need a decision yet, but it is part of a longer-term discussion. Today, we seek feedback from you that will lead ultimately to decisions. As a result, we have some guiding questions. We will not be seeking a motion at this time. At this point in time, I'm going to ask Denny Ogarindi, Policy Analyst, to walk Council through the update. And Denny, I'm going to turn it over to you now, please.
Thank you, Hanno. Good morning, everyone. Today, I'll be presenting draft options that have been prepared as part of the Practice Models and Corporate Dentistry Strategic Project, which will be followed by a discussion. As a reminder, we're not looking for decisions regarding whether the college should pursue any of the options today, but rather we're looking for your feedback on the options and to see which of the options you are interested in the college analyzing further. The first part of the agenda for this item will be a presentation. I'll be providing some background on the strategic project, as well as an overview of key findings and the draft options that have been developed. After this, we'll move into an update on next steps, followed by an open discussion of the options. Now, for some of you, this will be a reminder, but dentists work in various types of practice models. Some of these are more traditional practice models, such as solo or group private practices, illustrated by the images on the left-hand side. And these are owned and operated by one or more registrants, respectively. We also have corporate dentistry, which is a less traditional practice model, illustrated by the rightmost figure. This is a dental practice model whereby a corporation owns, aligns, or partners with multiple dental clinics and provides centralized operational support for the business or operational elements of the clinics. This includes things like staffing, HR, IT, procurement of equipment and supplies, etc. Additionally, direct-to-consumer dentistry is another model that we've looked at, and it's considered more of an emerging practice model. This is a dental practice model where dental treatments are provided directly to consumers. These include teeth whitening kits, mouth guards, and aligners to straighten teeth. For aligners in particular, dentists should be involved in evaluating patients prior to the commencement of treatment and monitoring patients throughout the course of their treatment, but generally they don't interact with patients. How did this topic of practice models come up for the college? Well, questions and concerns regarding the corporatization of dentistry were raised by interested parties, so for example, strategic plan consultation respondents. Additionally, media outlets have reported an increase in the number of practices that are owned by dental corporations, both in Ontario and across Canada. For these reasons, Practice Models in Corporate Dentistry was established as a strategic project in the college's 2023-25 strategic plan. This project has three objectives: to better understand the types of dental practice models operating in Ontario, to identify issues and opportunities, both perceived and real, for patients related to various dental practice models, including corporate dentistry, and to develop and implement options to promote and assure quality of care and ensure the effective regulation of dentists regardless of their practice model. It's this third objective that we'll be discussing elements of today. In terms of where we're at in this project, we've completed the first two phases of work. In the first phase, we gathered information through desktop research, which included a literature review, jurisdictional review of other professional regulators, and survey-based consultation of both RCDSO registrants and the broader public concerning their experiences and opinions on dental practice models. The second phase involved analyzing the gathered information to identify issues and opportunities and develop draft options to address those issues and harness those opportunities. And later this year, we'll be moving into phase 3, which involves council making decisions around the options that you would like the college to pursue, as well as the development of an implementation plan. So what were our key findings from this work? As you would have seen in Appendix A and B to the briefing note, various issues and opportunities related to dental practice models, that is, elements or aspects that can have negative or positive impacts on patient care, were identified through this project. Updates on some of the research that fed into these appendices were also shared with Council through updates in September and October of last year. Some of the potential issues that were identified include a loss of clinical autonomy by RCDSO registrants, financial conflicts of interest, organizational inefficiencies, and a lack of accountability or responsibility for both the dental clinic or patient care in some instances. On the opportunities side, this includes the potential for an improved focus on the provision of clinical care, an improved affordability of oral health care for patients, and improved physical access to oral health care for patients. Based on the potential issues and opportunities, and in particular where there is potential for negative impacts to patients, we've developed draft options for the college to consider in greater detail. In total, 6 draft options are provided for council's discussion today. All options were shared with the Executive Committee at its December 2024 meeting for discussion. And draft option 3, which you'll see, which concerns educational offerings related to dental practice models, was shared with the Quality Assurance Committee at its November 2024 meeting for discussion. Feedback from both committees has been considered and reflected in these options and will be highlighted throughout the remainder of this presentation. Another point I'd like to note before we get into the options is that the college has taken a practice model agnostic approach to the development of options to assure quality of care. This means that draft options have been developed to address specific issues or risks that may manifest across dental practice models for patients, rather than to regulate specific types of dental practice models. Ultimately, a clinic's ownership structure does not determine the level or quality of patient care delivered at a clinic, though objectives, policies, procedures set by clinic owners may have an impact on patient care, either directly on patients or indirectly. And additionally, with some of the less traditional models, like corporate dentistry, direct-to-consumer dentistry, we don't have a great deal of insight into the details of their ownership structures or business arrangements. Consequently, we did not feel it was prudent or necessarily effective at this point in time, in our view, and in most cases, to develop options on the basis of a particular practice model. With that said, as we go through the options, please keep track of those that you have feedback, questions, or concerns on so that we can discuss them at the end. There will also be a slide displayed at the end with all of the options listed to support that discussion. So for the first option, it's suggested that the college update and develop new requirements and recommendations for registrants to address unique issues for patients related to the business of dentistry. As described in greater detail in the briefing note, findings from the literature review and our consultation survey suggested that policies and procedures implemented by dental practices can have a direct impact on the practice of the profession by dentists and on patient care. Some of the areas that we've identified where requirements and guidance could either be developed or clarified to address some of these issues include ownership of dental clinics, financial conflicts of interest, maintenance of clinical autonomy, particularly for dentists who are not in complete control of their practice, so if they're practicing as associates or employees. And we could also consider if regulatory changes are needed to address certain topics or issues. So for example, requirements related to practice arrangements are set out in regulation. If the college, through additional analysis, identifies that more specific requirements related to practice arrangements are needed to effectively address risks to patients, those changes would need to be made through regulation. So how does this option support the public interest? Well, it helps to address risks that organizational practices that prioritize business interests can conflict with the provision of care in patients' best interests. Draft option 2 is similar to draft option 1 in that it would involve the development of new requirements and clarifying existing requirements. However, in this case, the focus is on responsibility and accountability, both for dental clinics and patient care, regardless of the model that registrants work in. We found through our research that there can potentially be issues related to both accountability and responsibility for the practice. So for example, if the owner doesn't practice in the clinic, there's no established practice manager, or the practice manager is not a registrant of the college, and so they're not as familiar with our requirements. We've also found there can be a lack of clarity in some instances or continuity regarding patient care. More specifically, if patients are seen as belonging to a practice rather than a specific registrant, patients see a different registrant each time they go to the clinic, or where there's a high turnover of associates who work at the practice. To address these potential issues, Option 2A would require a lead registrant in each clinic who is responsible for the oversight and supervision of the clinic for compliance with existing legislation, regulation, and college requirements related to the practice. So, for example, IPAC or staff training as examples. Option 2B would involve setting requirements or providing guidance that would clarify responsibilities for patient care in some of the scenarios that I mentioned a moment ago. This option helps to support the public interest by addressing risks related to quality and continuity of care in practice settings where responsibilities for practice management and/or patient care may be unclear. Draft option 3 is distinct from the first two in that its focus is on enhancing educational offerings for dental students in Ontario and RCDSO registrants that will help reinforce and illustrate their ethical and professional responsibilities regardless of their practice model. There are 3 components to this recommendation. The first involves adding scenarios to the college's jurisprudence and ethics course and new resources and questions to the college's practice enhancement tool. The second involves engagement with dental faculties in Ontario to identify opportunities and strategies that could be implemented to get students more comfortable with this topic, in particular as it relates to emerging or less traditional practice models. Finally, the third involves the provision of education directly by the college, so via an RCDSO Connect session or other avenue, to reinforce some of these concepts. Collectively, these components would help support the public interest by ensuring ongoing competence of dental students and RCDSO registrants on the topics of ethics and professionalism in all practice models, including emerging practice models. Feedback received from the Executive Committee on this option in December was that there is value in reinforcing these concepts for registrants, both when they're dental students, so prior to becoming a registrant of the college, and after they become registrants. Additionally, it was noted that in some instances, registrants, particularly associates and new associates, may not feel as comfortable raising issues, particularly ethical issues with the management of their clinic, and so providing education in this regard can be helpful. The Quality Assurance Committee also felt that there was great value in this option, in particular in suggesting both additional engagement with dental faculties and also suggesting the provision of additional educational resources by the college on this topic. Draft option 4 is probably the most innovative of the suite of options that are being shared with you for discussion today. As discussed in the briefing note, our jurisdictional review identified regulatory sandboxes and innovation hubs, which are described in greater detail in the note, as useful tools to help ensure effective regulation of new technologies or new business models. Based on this research, we developed this option, which involves developing a time-limited innovation advisory service pilot program that would provide guidance and help risk manage innovative business practices that have the potential to improve quality or delivery of services for patients. And the value in this option really lies in that public interest piece, wherein the program would provide an opportunity for proponents to raise inquiries with the college, to identify if a new concept or model fits within the existing regulatory framework, and ultimately seek non-binding guidance, which would help them to identify if they should move forward with an idea or perhaps make changes. Additionally, this option would help the regulator, so the college in this case, stay up to date on new trends. And both of these pieces would help the college regulate more effectively in relation to changing practice models. Operationally speaking, this pilot would build on existing guidance and support that the college already provides, for example, through its practice advisory service. This pilot, though, would have distinct objectives, a distinct vision for success, roles, and intake and response processes. And it could also include the support of a voluntary advisory body composed of independent subject matter experts to support the college in addressing topics that are maybe more complicated to address. Feedback received from the Executive Committee on this option in December was that this option could potentially encourage great collaboration, but may also come with risks. So for this reason, program design and risk mitigation strategies would be important if the college were to move forward with this option. Draft option 5 is straightforward. It involves developing resources or sharing pre-existing resources with patients to help them make informed decisions about the dental practice that's right for them. So for example, 5 questions to ask your dentist before joining a practice. It also includes a suggestion to develop a resource that would provide general guidance to dentists, so not new requirements, who are considering providing direct-to-consumer orthodontic treatment in order to support their professional judgment, given some of the risks that were identified for this particular practice model in your briefing note. I'll note that the college, on 5B in particular, that the college has provided guidance on the topic of managing patients who had previously received care through a direct-to-consumer orthodontic provider that shut down at the end of 2023. So the provision of additional guidance based on existing requirements and how they might apply in the direct-to-consumer orthodontic model wouldn't necessarily be new for the college. Feedback received from the executive committee on this option in December was that patient-focused resources in particular are very important to help patients better understand their options for care, and for those who want it to have more transparency in that regard. So the public interest piece I've spoken a little bit to already, but it helps to protect the public interest, this option, by enabling more informed decision-making by patients and by supporting the professional judgment of registrants. Draft option 6 is our final option for discussion today. As a reminder, we will be taking council's feedback on this option, but this option will not be put forward for council's approval as part of the final report, as it's quite operational in nature. This option involves the college considering opportunities to engage and to continue to engage with external parties, so dental corporations, dental faculty, even other colleges, on topics related to practice models and quality assurance. And this ongoing engagement is something in particular with dental faculties that was suggested by our Quality Assurance Committee. This engagement could take on a variety of forms. So as a few examples, we could seek feedback on standards from all of the above mentioned groups and engage with quality assurance staff at dental corporations to share information about new requirements as they come into effect and where they may impact the practice of registrants. We will also continue to work across college areas to determine if there are opportunities to improve existing information gathering and data analysis. And this will be done to advance our understanding and oversight of practice models or practice-related issues and opportunities. Ultimately, this supports the public interest by enabling the college to leverage opportunities to share and gather more information to generate insights related to dental practice models. So next steps and our discussion. Our next steps start with today, so we'll be obtaining your feedback and assessing your interest in pursuing the draft options. We will then be conducting additional analysis on the draft options that Council supports, including a thorough assessment of implementation considerations. We will then develop and share a report with recommended options for Council's approval later in 2025. And then we will proceed with the development of an implementation plan that outlines timelines, pace, and other considerations once recommended options have been approved by Council. So moving into the discussion, I'm just going to read through these questions and then I will pass it over to Angelo to display the summary of draft options up on the screen. The first question is, does Council have any feedback on the options, including any questions or concerns? Once we've had that initial discussion, we'll move into the second portion, which involves identifying which of the draft options Council supports and directs that we continue to analyze further, and which of the options does Council not support. So I will stop sharing my screen. Thank you, Angelo. Hannah, would you be able to coordinate going through this
Sure.
raised hands?
Thank you very much. So Council, we've set aside about 20 minutes for this part of the discussion, and there are going to be two major questions, so I'm going to be monitoring the time to remind you of that. I would encourage all of you who are speaking to either be as succinct as possible in your comments or your questions, and also I would like to encourage public members to make sure that you're part of this discussion as well. So I will start a list right now, and Daniel Haas, you're the first speaker on my list, please.
Great. Thank you, and thank you, Danny. That was a great presentation, and the briefing note was very helpful. I want to speak regarding option 3 about enhancing educational offerings. It's on page 109 of the package. And I'd like to suggest that the focus be, or the priority be, on 3C, and it should be done in coordination 3B. B, as you mentioned, is engaging with the faculties of dentistry, Western and Toronto, to strengthen the programs. As was alluded to in the Registrar's report, Western and Toronto aren't the only show in town. I mean, Toronto graduates 120, Western, it's about 70, I'm looking at a render, so less than 200 new dentists a year. The most recent data I saw on the RCDSO website was the 2023 report that said there were 680 new registrants, general certificates given out that year. So if you just focus on the schools, you're missing more than 2/3 of the new dentists in Ontario. And they're not just international dentists, they're dentists from across the country, the US, et cetera. So I really think your suggestion, or the suggestion of using RCDSO Connect or the New Dentist Symposium, things outside the dental schools will be much more effective, because we can only get to less than 1/3 of the students, no matter how good our programs are at the school. So the two should be coordinated, and I'd like the slight wording change in this briefing note versus December, where it was something effective reinforcing or enhancing what's going on at the school as opposed to starting afresh, because the students are getting this to some extent. So for sure, work with Western and Toronto, speak to those course directors, but you've got to come up with some other aspects, which, as you suggested here, RCDSO Connect, New Dentist Symposium, that will be much more effective in getting the message out. Thanks.
Thank you. Osama?
So very good presentation. I would just a quick comment. My thoughts are, does it have to be, like, do we have to pick one option? And can we, because some of these merge, and, you know, option 3 and 4, you could still have like an advisory component, but also have the courses and the online resources in option 5. So potentially incorporating some of the different options is a worthwhile consideration.
Maybe I'll just jump in quickly just to clarify. We're not looking to proceed with one of the suite of options. At this stage, we're going to be conducting additional analysis on however many, so from 0 to 6, that council's comfortable with us continuing to explore. And we can definitely pick and choose elements from some and integrate them into others, for sure.
Thank you. Mark Trudell?
Thanks, Hanno. Denny, thank you to you and your team. Great book of work here and very helpful. Council, I'd like the team to pay particular attention to option number 6. And in particular, when I think of corporate dentistry and I look at jurisdictions outside of Ontario, I think there's a great opportunity to capitalize on lessons learned in jurisdictions, in particular south of the border in the US. I'm not certain to what extent, Denny, your team is, how far down the road you are on this, or whether you're tabling the option or whether you've proceeded with some additional work on that front. But those external parties, I would suggest, should include entities that are well outside of the regulatory regime, regulatory colleges and jurisdictions and dental associations. But within the financial community, when I think of corporate dentistry, those models, those ownership models, are very broad, and they include entities the likes of private equity. And I think the college could tremendously benefit by that dragnet of outreach of external parties should be as broad as possible, in both jurisdictionally as well as entities. Thank you.
Thank you. Neil?
Good morning. Fantastic presentation. I'm looking at the option 2, where responsibility is under a dentist for each individual clinic. But I request some information. My understanding is that fee splitting can only be performed with another dentist or a hygienist. How is it that when you have a corporate structure of a CEO, board of directors, and shareholders, fee splitting is being performed at that level? What is the mechanism of action there?
So I can start off, and then I might pass it over to Dan and Andrea if they have anything to add. I think one of the points I mentioned earlier that's important to mention here is that we do not have all of the details or specifics of all of the individual corporate dental clinics or chains, their ownership structures or their business arrangements. You are correct that under current rules and requirements, dentists are only able to fee split with other dentists or with hygienists that work under them. But we're not in a position to really speak directly to kind of some of the more specifics of a lot of the corporations that are out there.
Alan, would you have anything to add to that?
I think the answer given was correct. We don't understand and we don't know how these corporate arrangements really function. But what you said, Neil, in terms of fee splitting is accurate in the sense that it's professional misconduct for a dentist to fee split with a person other than another dentist or a dental hygienist. So that's just the reality of the situation. So we'd have to have more information to understand what is really happening in the different so-called corporate entity relationships.
Thank you. Dan?
I just want to make a comment that sort of provides also some of that additional context to this option, which is, a lot of what we see through our regulatory functions is not knowing who's responsible in certain types of clinics, is fingers that are pointed in different directions that doesn't help us to get any closer to the truth. And so I think this option is really trying to help us to navigate the reality out there in terms of clinics with whatever type of ownership, and knowing when there's a complaint, if the patient doesn't know who the dentist was, or if it's a more generalized issue to the clinic, this will really help us to move closer to establishing a system that has accountability, essentially. So I wanted to make sure that that context is understood with this option as well.
Thank you, Dan. I'm going to move next to my speakers list. I would ask, once your question has been asked, if you could lower your virtual hand, and if you're not speaking, please turn off your microphone. And next on my list, Harinder.
Thank you, Hannah. I don't have a question. I just want to actually commend and congratulate Danny for coming up with this draft options to present to the council. And of course, it is early yet. We have suggestions coming and there will be more discussion. So thank you very much for your hard work. I know it's a very new and very complex issue, but we have to deal with it as regulators. And as just Dan mentioned, option 2 is something which I think other professions, if I'm not wrong, veterinarians have adopted that already. So thank you, Danny, for your hard work.
Thank you, Harinder.
Thank you, Harinder. Judith?
Thank you, and interesting presentation. I have to say that as a public member, I am a little concerned, and perhaps I'm overreacting, but I'm a little concerned that we have practice models that are operating where the college doesn't really know what the corporate structure is doing in terms, and I think that, as patients, I think that we need to know who the dentists are and who's ultimately responsible for that. I think that I agree that we need to have somebody who will be the lead dentist, if you will, because as far as I understood it, up until corporate dentistry, the only people that it was only dentists or I think hygienists who could own a practice. So now we have practices that are owned by corporations, and those corporate owners may be cut from a very broad cloth of people and not really have any knowledge of dentistry or the professional obligations of dentists or the rights of the patients. So I'm a little concerned, and I'm not understanding how, or let me just say this, I think that the college really needs to take a more aggressive approach to regulating offices that are part of a broader corporation. And, correct me if I'm wrong on anything there. I'm happy to hear it.
Thank you. I'm going to turn over to Dan for a response.
Yeah, I can start, and if others want to jump in, that's great. I think the first thing I would say, Judy, is that when we get any information to our attention, we can and do deal with it through ICRC, which I know all of you know that, but obviously you need information and evidence that allows you to deal with specific situations, and that's something that's ongoing all the time. I think I would agree with you in terms of your assessment, and this is something that formed the reason why it's a strategic project, that we need to get a better sense of how to manage the reality of what's going on out there and try in a number of different ways to get a better handle on this. And that might mean any of these options or any other ones as well. So it's a complicated issue, and we are dealing with individual circumstances when we know them. And we are also trying to establish a system that's going to put different layers of accountability that may not exist already. And I'm not sure if any other staff will have some comments on that, but I think you've raised a very important point.
Can I just ask a supplementary question there? You've said that a lot of this is being brought to light through the RCRC process, but that's when things have already gone wrong. I mean, ideally, the function of a regulator is to set things up so that things don't go wrong. I mean, obviously, things always will, but ideally, that would be the best case scenario. So it seems to me that rather than taking an approach of let's wait and see what's out there and we'll react to that, why could the RCDSO not take a more proactive position and say, this is what's acceptable to us, and the corporations have to figure out how to, fit into that mold?
Dan?
I think that's exactly why this is here, Judy. This is being proactive in terms of how do we understand what is actually going on there, and that's where a lot of this work has helped us to really understand that better. And you don't have all of it in front of you, but there have been a number of documents that have been provided to this table that looks at the environmental landscape, looks at the research, looks at the jurisdictional review. And that's led to an identification, in this case, of 6 options that we think are going to bring us forward as an organization to properly regulate. But we're catching up to some degree. We're dealing with individual circumstances as they arise. And this will allow us to be more proactively addressing those issues that can impact patient care and quality of care.
Okay, thank you.
Thanks, Dan. Council, I still have 6 people on my speakers list. We want to get to them all, so I'm going to remind you to please be as brief as possible in your comments because we still have another question that Denny is interested in your feedback on. So next on my list is Daniel Fortino.
I'm going to make this quick because it's been addressed a few times, but option 2 I think is critical, going to Judy and Dan's points. A lot of the times the continuity of care in these type of setups are disrupted and patients don't understand who's treating them. There's multiple associates that run through the practice and there's a high turnover rate. So I think liability and responsibility, like a lead registrant, they have something similar in Alberta, I believe, which is something we could look at and look at their model and how they kind of delegate responsibility in these corporate models. But I think going back to our sort of mandate overall public safety measure, it's important to have someone who's really liable and responsible for that continuity of patient care. So it's just kind of reiterating that option 2 I think is essential and something to really focus in on. Thanks.
Thank you. Anthony Mayer.
Thank you, Hanno. Once again, I want to compliment Denny on a very thorough and comprehensive report. I have several things I want to say, so I'm going to try and say them quickly. I think it's important for us to understand that both the concerns and potential benefits of so-called corporate dentistry can also exist in a single practice, single owner model. It's quite possible that there could be one registrant in one location who has multiple doctors working underneath them, and that registrant maybe does very little so-called hands-on work in that practice. And that would exist as a de facto corporate model, regardless of the fact that it's only one registrant and one location. So when we apply these rules, they should be applied universally. So I'm all in favor of number 1 and number 2 becoming just one rule that's applied to every location where dental care is offered to patients in Ontario. I'm totally in favor of number 3. I think Dan's point was very well taken. When I first read number 4, not to be facetious, but the word that came into my head is boondoggle. So I looked it up just to make sure it was correct. And a boondoggle is work or activity that gives the appearance of having value, but is actually wasteful or pointless. So there could be value here, but I think we're going to need a lot more information about number 4 just to make sure that it doesn't turn into one of those things. And I'm going to stop there. Thank you.
Thanks, Anthony. Brian Smith?
Thank you, Hanno. My thanks as well to everyone involved in bringing this project along. It's an excellent food for thought for all of us, and the recommendations reflect that. I also like, as a public member, to see the strong recognition throughout the whole document and the summaries of the public interest that we're here to serve, and that's reflected in a lot of the document. I think the ones that I particularly like around that are item 4, notwithstanding the boondoggle, number 5 and number 6, because to me they will bring forward additional, if you like, protection and involvement and recognition of the importance of the public that we're here to serve. So well done, and we look forward to putting this in practice. Thank you.
Thank you, Brian. Eliad?
Hello. I just wanted to contribute, just working downtown and being exposed and working in a corporate dentistry model. We need to be more careful of not just dental corp, like the big umbrella companies, these pseudo corporations of dentists who have bought out many practices, and they're starting to form their own structure, their own regulation, and sometimes their own policies that goes against the autonomy of the dentist. So I think that's one issue that we need to focus on. In my practice, the owners that own the clinic don't even live in the country. So it's very difficult for them to have any accountability, and they just have managers and different HR people that are involved. And sometimes it becomes a little bit difficult in patient management. So some of that should also consider.
Thank you. Erin?
Thank you. I think what's especially powerful about this project is that instead of tying it to any particular model, we're tying it back to the risk to patients. So that was a very good call, and I think is going to help us frame this moving forward. One thing that stood out, though, in that regard is that we do need more information because, as a number of people have already touched on, there's a lot of different arrangements. They're evolving. This is something that's going to keep evolving over time. So in order to do that, I think we need to really ask specific questions that have to do with the risks. So what is the exact risk? What are the complaints that we're seeing? How many complaints? What is the nature of the complaints? And are these associated with some specific feature, whether it be a billing target or something else? And then how do we get information on that specific feature so that we can develop recommendations and requirements? And I think that will really be a solid foundation going forward, and keep it at its basics instead of constantly chasing behind the truck as different innovative models start to pop up. And that will allow us to focus on risks and keep it in the patient interest and keep it patient-focused.
Thank you. I have Deborah and Nolan left on my speakers list. So Deborah, I'm turning it over to you now, please.
Thank you. An excellent presentation. I think this topic is really important, and we should continue discussing it. I just wanted to follow up on particularly what Judy said regarding being proactive. Is it possible to create a survey directly to dentists, asking their feedback on the existing models that are coming out to practice dentistry? It could be a model that's responded anonymously, so we can sort of nip things in the bud before finding to the point where it gets to a complaint level. I'm just suggesting some sort of survey and open comments that can be made addressing some of these issues. Other area you can look at is if you see a dentist leaving a location, maybe asking that, maybe proactively just having a phone call to the dentist, why did you leave that practice, to find out what the reason was. Was it because of management? Was it something that you weren't comfortable with the management? Because dentists are very, to me, very loyal, dedicated group of people. And if they leave, it's a sort of a bit of an indication something that was wrong and that they have to leave because there was a problem. They had no other place to voice their opinion. They just had to leave the situation. So there is a way to be proactive on something like this, in my opinion. Thank you.
Thank you, Deborah. Denny, did you want to respond?
Yeah, if I could just jump in quickly on your first point. Thank you, Deborah. The one thing I'll note is that we did conduct a consultation survey to inform some of this work, and we received quite a good response as far as the college's surveys are concerned. So we received about 595 responses, a lot from dentists, but also other oral health care professionals. So we had a strong response from hygienists as well. And we had over 2,000 open comments on the topic of practice models, both registrants and the public based on their own experience, but also their opinions, and we delineated in that way. So a lot of that work has informed some of the issues and opportunities that we've identified. That said, where you see some other professions tackling some of these issues, so pharmacy in particular, they continue to consult and engage as the landscape changes and as they issue direction and policies. So I think that's something maybe moving forward, if we move forward with some of these initiatives in particular, we can consider to continue to do.
Thank you. And last speaker on my list is Nolan.
Thanks, Hanno. Just a quick question. According to the Dentistry Act, according to the law, does someone who does not hold, so if someone does not hold a license by the RCDSO, are they allowed to own a dental practice in the province of Ontario?
Can I ask, I'm going to throw that over to Alan.
The difficulty is the way dentistry is controlled in Ontario is twofold. First and foremost, through professional misconduct regulations and what a dentist is or is not able to do without committing professional misconduct. So someone earlier commented upon the splitting of fees. You can call it illegality, but it's really an act of professional misconduct to split fees with someone who you're not entitled to split fees with because of the regulation. The problem with ownership per se is, what does that mean? There's all kinds of things you can do without committing professional misconduct. A dentist can do without committing professional misconduct. And then there are things that they can't do without committing professional misconduct. And I don't know, personally don't know, what the word ownership means within these different frameworks that we have. I've never personally seen, over the lengthy career I've had, a set of documents which establishes what the relationship is with the dentist and the other entity that you might say, quote, owns the practice. So I don't know if they own the practice or not. You know, there are rules allowing for someone to provide all kinds of dental services, not treatment, but other than treatment, like hiring the dental assistants and managing the receptionist and providing human resources and financial assistance. All those things are permitted. That doesn't create ownership of a practice, but it there are arrangements with third parties who are involved in the dental practice. What the exact structure is and what ownership means, I don't know, and I don't know that the college knows yet. And there's so many various forms of it. And I think we're using ownership in a very broad sense because we don't really know who owns them. We know that, except in very limited circumstances, the patient records need to be controlled by dentists, for example. We know that. And that in terms of legality, only a dentist or a dental professional corporation can actually practice dentistry.
Thank you, Alan. I know Dan wants to make a quick closing comment. We have gone way over our time allotment. Anthony Lichot, you're the last person on my list, so I'm going to turn it over to you and ask you to be very, very quick, please.
Thank you, Hanno. Yeah, just to build on what's already been said, from my understanding is that with these DSOs, if you could kind of think about it, that they own everything other than the dental chart. So they own the facility. And so their arrangement then to get compensated for what they own and the services that they provide from a business standpoint and an HR standpoint is where they make their money. With regard to then transferring, let's say when they sell it, they basically take one dentistry corporation, professional corporation, and basically it goes to another dentist, and that dentist's professional corporation owns the charts and is responsible for the charts. But just on a very, very straightforward scale, they own everything but the charts, or they control everything but the charts. A dentist must control the charts. Thank you.
Thanks, Anthony. And Dan, I'm turning it over to you for closing.
Very quickly, and I think as much as we can try to catch up, I suppose, in terms of the different arrangements that exist, but remembering that our oversight is of dentists, so we're really trying to ensure that dentists, regardless of the practice model, are performing according to the standards and expectations of the college. And I've heard it a couple of times. I just want to be clear, it may not be entirely evident from the materials or the discussion to date, but the design is to be practice model agnostic. The design is to be, what will we expect of the profession, regardless of the type of ownership model that might exist? And, possibly can we anticipate what type of ownership models might exist in the future? But this will allow us to kind of separate the two, not that we would ignore the one, but to separate the two and focus on what this college has oversight of, dentists.
Thanks, Dan. Denny, I'm going to turn it back over to you now, please.
Thank you very much. We just had a final question, and I think this might be pretty quick. It sounds from the discussion in the room like there's comfort at this stage at us continuing to explore all 6 of the options that were put forward. But if there's any disagreement with that, please feel free to raise your hand and can go from there. Okay, not seeing any. Thank you very much, Hannah.
And thank you very much for that presentation, Denny. And Council, thank you so much for the amount of feedback and the number of people who provided that feedback. That was great. We are running behind, so what I'm going to propose now is that we're going to take a 15-minute break. When we come back, we will resume with item number 8, which is on the agenda. That still will be in the public forum before we move in camera. So it is now 10:53. Please come back here at 11:08. And we will commence with item number 8 on the agenda. And I would ask you to turn off your cameras when you step away, please. Thank you. The Professional Liability Program, the PLP, including current liabilities and staff, to a third party is underway. Once the RCDSO no longer owns and operates the program, the college will need to identify a way to ensure that all registrants have coverage. At our last meeting, Council agreed to send out the proposed amendments to the regulation for consultation. The consultation was open for 60 days and just closed on March 25th. The material for this part can be found in your package on pages 128 to 155. This item is for Council's decision. Just a reminder, Council, you did approve in principle the regulation direction in January. This is the second time that you will be reviewing this topic. Hilary Bauer is the college's manager, registration. Hilary, I'm going to hand it over to you, please, and your advisor, Margot Orchard, to walk Council through the report and the recommendations. Hilary.
Thank you very much, Hanno. Angela, if you wouldn't mind sharing the slide deck, please. Okay, so good morning, Council. As Hanno mentioned, we're here today with an update on the registration regulation amendment following the 60-day consultation period. So as Hanno said, you in January made a decision to, in principle, release the draft amendment for the required 60-day public consultation, which concluded just 2 days ago on March 25th. And now we're asking Council to formally approve the registration regulation amendment and direct staff to make a submission to the ministry on the amendment. The package of materials is at page 128 with the detailed briefing note, as well as a summary of the feedback we received through the consultation. Next slide, please. So the purpose of the discussion today, first I'll take you through a bit of a refresher on the content of the proposed regulation changes. Then Margot Orchard beside me, who you also heard from in January, will walk you through the consultation feedback received on the regulation amendment, as well as our proposal for Council's consideration. And then we'll present a motion to Council to both approve the regulation and submit it to the ministry. Next slide, please. So you'll recall that the main purpose of the proposed amendments is to the regulation relate to the divestment of the professional liability program. Council is aware of the current ongoing procurement process to divest PLP. And once PLP is divested and we no longer own and operate the program, we will require a mechanism to ensure registrants have liability protection. In order to do this, we need to amend the registration regulation, specifically to do three things. First, to make professional liability protection a requirement for registration. So that means that all dentists will be required to have liability coverage as a basic condition of registration. Second, the amendment establishes an ongoing obligation to maintain professional liability protection, and that's done through a term, condition, or limitation. So what that means is that where there are lapses in coverage, the TCL prohibits dentists from practicing. Lastly, the amendment provides a mechanism for the college to respond to any lapses in coverage, or if there's a failure to provide proof to the college of that coverage. And this will be done through suspension provisions. And you may recall that we are applying a right touch approach to these amendments. So where there are lapses in coverage, a dentist can apply to the college and provide evidence to correct those deficiencies, and the registrar can lift a suspension in a 60-day grace period. After that point, a license would be revoked and a dentist would have to apply to reinstate. Next slide, please. So even though the main purpose of the regulation amendment is to address the need for a mechanism to require and enforce liability protection, we're taking the opportunity to propose a few additional amendments to streamline registration processes where we've identified a need to enhance public protection, reduce unnecessary barriers to registration, and anchor it to best practices of other colleges. These amendments are in three areas. The first relate to the reinstatement provisions, where we've added additional exclusions to prohibit reinstatement where there are significant character or competency concerns. Again, these already existed. We're just adding a few additional exclusions to that list. Secondly, relates to work authorization. And the aim of this amendment is to ensure that dentists maintain work authorization while they're practicing through a term, condition, or limitation. As a reminder, this is already a requirement for registration. We're simply introducing a mechanism that requires dentists to maintain that work authorization. Lastly, we are proposing amendments to what we call the continuous practice requirements. And the goal here is to remove unnecessary barriers for dentists who have recently been in practice or have recently demonstrated competence through specialty licensing exams. Okay, so I'm going to pass it over to Margot now, who's going to take you through the details of the feedback that we received before presenting a motion to council.
Thanks, Hillary. Next slide, please. So before going into the details of the feedback, I'll provide you with a brief overview of the process that we went through. As was noted, Council reviewed these regulation amendments on January 23rd and provided approval to have them posted for consultation. That went out quickly on January 24th, and the consultation was open for the required 60 days. We provided an interim summary of the consultation results based on results received up to March 10th, and those are included in your council package. And since then, the consultation closed on March 25th, and we're here today to provide an overview of the final results. I should note that the consultation process also includes a 45-day posting on the Ontario government's regulatory registry. This is typically done at the same time as the college is posting, but it had to be delayed this time due to the Ontario election. The ministry has indicated that they are now moving forward with the approvals process, and we're hoping that that gets posted pretty soon. And if there are any substantive comments that come through that process, we will be sure to bring them back to council for further reflection. Next slide, please. The college's consultation process was done through an online survey, and 117 surveys were received. This is 3 more than what was included in the briefing note package. Of these surveys, all the respondents identified as dentists, with the exception of 1 who identified as a patient or public and 1 organization. The organization that submitted a response through the survey was, interestingly, the Alberta Dental Association, and that came in after the briefing note was developed. The survey's sole question was, do you have any feedback on the proposed regulation amendments? And only 71 people clicked through the survey and provided a written response to that question. I should note a written response was submitted separately by the Ontario Dental Association, so that brings us to 72 submissions. Of all of the submissions, only 14 were related to the regulatory amendments themselves. And I should note all of those were included in your briefing note, with the exception of the ODA and the Alberta Dental Association submissions, which I'll tell you about in a moment. Next slide, please. As I mentioned, only 14 responses provided input that was related to the regulation amendment. The vast majority of other feedback received was related to the divestment of PLP itself. Some indicated a lack of understanding of the rationale for divestment and asked for the status quo to be maintained. Others flagged the expectation that the college should make sure it reduces its registration fees to reflect the divestment of PLP. These are all important comments, but the feedback doesn't affect the regulation itself and can be better addressed through future communications and policy tools. The most prominent theme that was related to the regulation was related to expectations for non-practicing dentists. There were 9 people who provided input on this topic, and they were interested in the professional liability protection requirements for dentists who may be retired, semi-retired, work in academic or research capacities, and don't currently practice but want to maintain their license. Most were looking for clarification, and others requested an exemption be created to remove the requirement that they hold professional liability protection if not practicing. It's important to acknowledge that the college does not currently have a non-practicing class. So this means that all current members of the college, regardless of which class they belong to, and whether they are actively practicing, have the authority to perform authorized acts. And it's a critical public protection requirement that they have valid professional liability protection, because at any point they could be subjected to a professional liability claim, even related to non-clinical activities like teaching or research. Down the road, if the college should decide to explore the creation of a non-practicing class, then the requirements for this class to have liability protection could be further explored. But for the time being, we're suggesting the regulation remain as is to ensure full protection of the public. There were 2 additional comments that were submitted related to other parts of the regulation. The first related to implementation of the continuous practice requirements, and no changes to the regulation are being proposed in response to this comment, but the respondent did highlight the importance of being proactive and clear in the communication of changes once the regulation is in place. The second comment was related to the pre-existing reinstatement requirements. There was some concern about the fact that someone who's under an ongoing investigation is ineligible for immediate reinstatement. This feedback was related to criteria that already exist in the regulation, and the exclusions exist to ensure immediate reinstatement is only available to those without significant character or competency concerns. So as a result, no changes are proposed in response to this either. Next slide, please. I'll finish up by sharing the feedback that was received from the Ontario Dental Association. They submitted a letter that outlined their support for the college's continued requirements for malpractice coverage of all registrants. In the letter, they acknowledged the RCDSO's commitments to maintaining a seamless transition for registrants. And they also mentioned their support of the changes to the reinstatement provisions and the public protection benefits that are associated with those changes. No other feedback was provided related to any other aspects of the regulation amendments in the ODA's letter. Interestingly, the survey was also completed by an individual who claimed to represent the Alberta Dental Association, and this respondent also expressed strong support for the college's decision to divest the PLP. Next slide, please. This concludes the summary of the feedback received, and given the nature of the feedback, we're proposing that the amendments be approved as circulated with no additional changes. Next slide. If council agrees, we'll proceed with submitting a package to the ministry for review and approval. And as I mentioned, the regulation amendments still need to be posted on the Ontario Regulatory Registry, and we'll let this process run its course and bring any substantive feedback to council if there's anything new and different that comes through that consultation. I'll remind you that the regulation amendments that have been drafted need to be reviewed by the Minister of Health and then approved by the Lieutenant Governor and Council. And a part of this involves the government's Legislative Council going through the regulation and potentially redrafting the wording to ensure consistency both within the regulation and also across other provincial legislation and regulations. So although the wording may change a little bit, we do make sure that council's direction and intent remains clear and well represented. So although it's out of our control, we do continue to hope and expect that the regulation will be approved by Cabinet by the end of this year, and we'll be working closely with the ministry to facilitate this. Next slide, please. And today, we're asking for your direction on 2 main points. We're asking you to approve the draft amendments as currently worded, assuming that no substantive feedback is provided through the Ontario Regulatory Registry. And we're looking for your direction to have the college staff make a formal submission to the ministry as the required next step in the process. I'll pass it back to Hanno now.
Thank you. Thank you for that. So at this point in time, I am going to look to council to see if there are any questions or comments in terms of what you heard from Hillary and Margot. Seeing none, could I have motion 2A on the, okay. Could I have motion 2A on the screen, please? And for your consideration, Council, motion 2A is that absent the receipt of significantly different feedback through the Ministry's regulatory registry, that Council approves the amendments to the registration regulation as currently worded. And that's moved by Deborah, seconded by Vivian. All those in favor, please raise your virtual hand. And that motion is carried. Thank you. Next motion, please, is motion 2B. And that motion for your consideration is that Council directs RCDSO staff to make a formal submission to the Ministry as required by the Ministry's processes. That is moved by Judith, seconded by Anthony Lisho. All those in favor, please raise your virtual hand. And that motion is carried. Thank you very much. And thank you, Hilary and Margot. At this point in time, staff, we're going to move on to the next item of the agenda, which is going to be our in-camera session. So if I could have motion 3 on the screen, please. And motion 3 is that Council exclude the public from the meeting to receive legal advice and/or opinions from the college's solicitors in accordance with Clause 7(2)(e) of the Health Professions Procedural Code, which is Schedule 2 of the Regulated Health Professions Act 1991. That is moved by Christina, seconded by Jamie. All those in favor, please raise your virtual hand. And that motion is carried. Thank you very much. So for those who are observing from the public, we are going to be going in camera now, followed by lunch. So please keep your eye on the screen, but we should be back in the public forum at around 1:30. It could be a little bit early, so check your screen, but that's what our intent is right now, to be back in the public forum by 1:30. So we will pause for a few moments for staff to leave, and then for those who are remaining, just be reassured that IT will be moving us into a breakout room for this conversation when we are about to begin.
Collaborative work, both with our external experts, Pivotal Research, and internally with my thought partner and colleague, Michelle Cabrero-Gali. It's so important to understand our objective here in this room and always is to serve the public, but to better understand what the public thinks about us. So we have a unique perspective on that to share with you today. We have 2 experts joining us from Pivotal Research, Doha Mellon and Jessica DeVries, and I'm just going to give you a brief introduction to them. Doha Mellon is the Vice President of Consulting and Chief Evaluator at Pivotal Research. It's a firm specializing in research and evaluation for professional regulation. Pivotal is a partner of the Canadian Network of Agencies for Regulation, CNAR, and an accredited member of the Canadian Research Insights Council. Doha is a public policy expert with over 20 years of experience in workforce development, strategic policy reform, and evidence-based regulation. She currently leads multiple research and evaluation initiatives focused on advancing healthcare outcomes and strengthening regulatory practice across the country. Doha holds a Master's of Public Policy from Johns Hopkins University. Doha's colleague, Jessica DeVries, is the Director of Program Development at Pivotal Research. She brings over a decade of experience working with healthcare regulators across Canada, leading research and engagement initiatives that support public trust, performance measurement, and regulatory transformation. Jessica's helped expand the voice of the patient, which you'll hear more about, into a multi-profession, multi-jurisdictional program across Canada, in Ontario, Alberta, and British Columbia with several regulators, and we're now using it, and a number of them are now using it as an annual survey tool. Jessica works closely with oral and allied health regulators on public polling and registrant engagement to support amalgamations and team-based care transitions. Jessica holds a Master of Arts in Community Engagement and a Bachelor of Science in Mathematics from the University of Alberta. So I will hand it over now to Doha and Jessica.
Thank you, Leslie. I'm just pulling up a set of slides to be guiding our presentation here. Let me know when you're able to see it. Okay. Thank you for the opportunity to be with you today. We're pleased to present findings from the Voice of the Patient research conducted in partnership with RCDSO. This work reflects a growing commitment across regulatory bodies to incorporate public and patient perspectives into regulatory thinking. Our goal today is to share what we've learned from Ontarians about their experiences and perceptions of dental care and regulation. We'll start with a quick overview of our approach and then walk you through the key findings. This research supports the college's role in protecting the public and promoting safe, equitable, and competent oral health care through profession regulation. RCDSO commissioned this study to better understand how the public in Ontario experiences oral health care and how they view the dental profession. First, we set out to ascertain public perceptions of their oral healthcare experiences. Secondly, to explore beliefs about dentist responsibilities and what the public expects of the profession. And thirdly, to understand public awareness of dental regulation, who people believe holds dentists accountable, and how visible the college is to Ontarians. These objectives help shape both the survey design and the analysis you'll see in the findings ahead. In terms of data collection methodology, we conducted an online survey with a province-wide sample of Ontario residents aged 18 and older. In total, 2,000 surveys were completed between October 28th and November 14th of 2024. The sample included two key respondent groups. Recent patients, those who received oral healthcare or accompanied a dependent in the past year. Non-recent patients, those who hadn't had any engagement with oral health services or dental health services in the last 12 months. 79% of the sample were recent patients, and while 21% were non-recent patients. I'm going to hand it off now to my colleague Jessica to go over the patient journey experience results. Jessica?
Wonderful. Thank you, Doha, and hello, everyone. As mentioned, I'll be walking you through the results from recent patients. So when we think about who is visiting the dentist, we found that most are engaging with dental care. So 79% of our respondents reported visiting a dentist in the past year, as Doha mentioned. So it was either for themselves as a patient or to accompany a dependent, or both. As you can see here, access is closely linked to insurance coverage. 82% of our recent patients had some form of dental insurance. 40% were through an employer, and it's actually an additional 16% if we include the spouse or the partner's insurance, and 26% access it through government programs. When asked about why they last visited a dental office, preventative care is the most common reason. 72% of recent patients last visited for a routine checkup or cleaning. And what we do see in the data is that those who have insurance from non-government sources are more likely to visit for routine or preventative care compared to those who have government coverage or no insurance at all. Okay, so while we'll explore different metrics along the patient journey, one of our key measures is this overall satisfaction with their most recent experience. And as you can see here, overall satisfaction is quite high, with 82% of respondents reported either being satisfied or very satisfied with their last oral health care experience. In particular, satisfaction was highest among older adults, who are defined as those that are respondents aged 66 and older. And we actually see this for a number of different aspects along the patient journey as well. However, there were some notable differences. Satisfaction was a bit lower among respondents from marginalized communities, with 77% reporting they were satisfied overall with their experience. And similarly, we saw lower satisfaction at 78% for those whose first language is in English. All right, before we dive into the details, this graphic gives us a good snapshot of the full patient journey, really starting from that booking and pre-treatment process through to consent, the procedure itself or treatment, and follow-up. We'll walk through each of these stages in more detail and really highlight where satisfaction is strongest and where there may be opportunities to improve the patient experience along the way. And we'll also talk about a key driver analysis too. So the percentages that you see here reflect top 2 box scores. So that is the proportion of respondents who said they were satisfied or very satisfied throughout each of those aspects. So when it comes to aspects of the dental office itself, we can see that 81% of respondents were satisfied with the cleanliness and infection control measures, and this received one of the highest scores compared to the other aspects. Any of the scores you see that are 80%, those are going to be the higher one, and we had a handful of those throughout the patient journey. However, you will see that 62% were satisfied with their ability to access care on short notice, pointing to a potential challenge around timely access. As mentioned previously, satisfaction was higher among older adults on both of these aspects. And while respondents in the Toronto region reported lower satisfaction with cleanliness compared to the overall sample. So that's just a little bit of a demographic difference we noted here. As we move here on to the pre-treatment stage, we asked them to rate 4 aspects of their experience. And they expressed the highest satisfaction with the time spent explaining treatments or procedures and answering their questions, with 7 in 10, or 71%, reporting they were satisfied. 2/3 were satisfied that their dentist prioritizes their oral health care above all other interests. And this is an interesting one. We will be revisiting it in the driver analysis. And we saw that satisfaction was slightly lower for the time and space given to patients to consider treatment options at 64%, and then the information provided about the costs and recommended treatments or procedures was at 62%. Okay. And now when it comes to the examination and treatment components itself, there are 3 aspects that we asked them. And you can see here that satisfaction was really strongest around communication. So the ability to ask questions during treatment received the highest rating in this stage, with 75% of respondents reporting satisfaction. 7 in 10 were satisfied with the options provided to minimize pain and discomfort, and a similar proportion, so 69%, were satisfied with how well their provider considered other health needs or conditions during their treatment. And so as with other parts of the journey, satisfaction again is increased for those that are older adults, but we did notice there were some differences by language. So patients whose first language is not English reported lower satisfaction with their ability to ask questions during treatment compared to those whose first language is English. When it comes to the consent process, patients were asked about 3 key aspects, and satisfaction was consistently strong across all 3. So 75% felt they had enough information to provide informed consent. 74% were satisfied with their ability to participate in decisions about their care. And 73% did not feel pressured to choose a particular option. And we see that patients in the Toronto region were more likely to report lower satisfaction compared to the rest of the province across these 3 attributes. These next set of results focus on patients' interaction with office staff, well, the whole oral health care team. And so you can see here that satisfaction was highest with respect shown by the oral health care team, followed closely by the clarity and understandability of both written and verbal communication, each with around 8 in 10 participants reporting satisfaction. 3/4 of patients were also satisfied with the education they received on how to care for their oral health, as well as the time staff took to build rapport. And however, we did note that patients who identified as belonging to racially marginalized communities did report lower satisfaction across several attributes, particularly when it came to building rapport, receiving clear communication, and being treated with respect. And lastly, when it comes to care delivery, most patients felt their expectations were met. So 8 in 10 were satisfied that the care they received aligned with what they expected. And satisfaction was lower when it came to cost-related aspects. So just under 7 in 10 were satisfied with how well actual costs aligned with estimates and with the clarity of any explanations for changes if needed. And so to understand what drives a positive oral health experience, we conducted a key driver analysis, and that helped us to identify the attributes with the greatest impact on that overall satisfaction experience metric that we talked about at the beginning, that 82%. So when it comes to key drivers where the oral healthcare team is performing well, we can see a strong driver is that oral healthcare was delivered as expected. Very important, high impact, and performing well on. Clear and understandable communication is also deemed as vital, both verbal and written, and it was a top performing key driver. And also the taking time to build rapport is came as a really important one as well too, with the 74% satisfaction rating. And so comparatively, it is also seen as a top performer for the dental care experience. So the analysis also identified areas that are critical to patient satisfaction. So these are our key drivers as well, but where current performance is lagging comparatively when we look across all the items. So accessing care on short notice, again, remains a concern. So we have 62% were satisfied here. And you can also see that 3 of these items all happen within the pre-treatment phase. And so they're flagged, the ones that are flagged are having enough time to consider treatment options and feeling their care is prioritized. And really taking that time and explanation of procedures, including risks and benefits and answering questions also. I mean, even though those scores are not low, I mean, we see 71% for taking time to explain treatment and procedures, it still showed some room for improvement, as we know this has such a high impact on the overall satisfaction. And the remaining key driver that also is impactful in the post-treatment phase really comes down to costs. Do costs match what was estimated, and any charges were satisfactorily explained? So these are some key drivers that could potentially, we'd like to see some improvements in as we move forward. Thank you, Doha, and I'm going to turn it back over to you to talk about those who are not visiting.
Thank you, Jessica. So who is not visiting the dentist? While most Ontarians access dental care, 1 in 5 respondents, about 19%, said neither they nor their dependents visited a dentist in the past year. The primary barrier to accessing care was cost, cited by 51% of non-recent patients. This includes both out-of-pocket expenses and lack of insurance coverage, a finding consistent with national data from Statistics Canada, which shows that nearly a quarter of Canadians have avoided dental care due to cost. Other contributing factors included insufficient insurance, not feeling the need for care, and for some, fear of pain or past negative experiences. We asked non-recent patients what actions they took when they were unable to access necessary dental care. About a quarter reported they were eventually able to obtain care when they needed it. Among those who could not access care, the most common response was doing nothing, followed by self-medicating, typically using over-the-counter options. Some turned to urgent or primary care, others sought financial help, and a small group even considered or attempted self-treatment. This question asked all respondents, not just recent patients, to rate their overall perception of the quality of dental care in Ontario. It's not based on their last visit or personal experience, but rather their general impression of the system. As you can see, there's a notable gap. 63% of recent patients rated the quality of dental care as high, compared to just 39% of non-recent patients. So those with direct and recent contact tended to hold a more positive view. Perception of quality didn't differ significantly based on whether someone had dental insurance. There's a broad agreement across both groups, patients and non-recent patients, that dental offices should be accessible to people with disabilities and that care should be available regardless of ability to pay, highlighting strong public support for equitable access. Recent patients were nearly twice as likely as non-recent patients to say they could find a suitable dental clinic in their community, 74% versus 41%, suggesting that direct experience improves perceptions of access. About 16% of respondents agreed that dental patients in Ontario face discrimination, whether from the dental clinic overall or from individual dentists. This result is consistent with 2024 findings from the College of Dental Hygienists of Ontario, a Voice of the Patient program, which we managed for them, indicating a broader pattern. Approximately 1 in 5 respondents either said they didn't know or selected a neutral response, which may reflect discomfort, uncertainty, or lack of awareness. Perceptions of discrimination were higher among racialized individuals, newcomers to Canada, and members of the 2S LGBTQIA+ community. Younger adults, those under 35 years of age, were also more likely to agree with the statement than older respondents. Okay, here with regards to dentist responsibility, the public holds dentists to high standards as clinicians and as well as stewards of equitable care. But 79% believe dentists are responsible for ensuring fair and respectful care for all individuals. 71% say dentists should advocate for patients by addressing individual needs and barriers to care. And another 71% expect dentists to patient well-being above all other interests. Here we ask respondents what factors they believe dentists should consider when deciding whether to accept a new patient. 77% said the urgency of the patient's care needs should be a key factor. Another 77% emphasize the importance of the care being within the dentist's scope or expertise. And 72% felt dentists should also consider whether they have the capacity or time to take on the patient. Here, with regards to awareness of regulator, just over half of Ontarians surveyed, but 55% overall, were aware that there's a regulatory body overseeing dentists in the province. Awareness was higher among those with recent dental experience, but 58% of recent patients were aware of a regulator compared to just 42% of non-recent patients. This level of awareness is notably higher than findings from other oral health regulators that we conduct VOP studies for. For example, in 2024, 42% of Ontarians were aware that dental hygienists have a regulator. In BC, 2023 results showed 37% were aware of regulator overseeing oral health professionals. A little more here on awareness of the college, the Royal College of Dental Surgeons of Ontario. 31% of Ontarians surveyed had heard of RCDSO. Awareness was higher among patients than non-recent patients. For context and for comparison, awareness of the College of Dental Hygienists of Ontario was 23% in 2024. So RCDSO awareness is slightly higher. Among those who are aware, 56% of patient respondents and 44% of non-recent patients believe the college is effective in fulfilling its public protection mandate. Those who are familiar with RCDSO most often learned about it through friends or family, about a quarter, or from their oral health professional, 21%. When asked how RCDSO should communicate with the public, the top two preferences were public awareness campaigns and printed materials in dental offices or clinics. More than half also chose social media and the RCDSO website, reflecting interest in digital engagement alongside more traditional approaches. And just over a third selected multilingual informational materials, pointing to an opportunity to better reach diverse communities. Okay, here I want to spend a moment to walk you through the interactive dashboard that came along with this study. A link to the dashboard was shared with you. It allows you to explore the data in more depth with the ability to filter by age, region, income, and whether respondents identify as racially marginalized. I'll give you a quick tour of the 4 pages so you know what's available. I'm going to do that right now. Let me see if you're able to see the dashboard. Are you able to see it?
We can see the dashboard, yes.
Okay, perfect. So page 1 is the landing page. It allows you to navigate into specific pages within the dashboard, you know, kind of aligning to the data that we and the results that we shared with you earlier on the slide deck. Here,
Sorry, Doha, I think you're
yes?
showing the slide. This is the slide. So I think we're still seeing the slide screen as opposed to the live dashboard link.
Okay, so I'm just going to stop sharing and then reshare quickly here so you're able to see the dashboard. Okay, if you're able to see the dashboard.
Perfect, yeah.
Okay, so that's the landing page. On to the next page here. It shows you who's accessing dental care and captures satisfaction across the patient journey. As we've discussed here, you're able to filter through dental office, pre-treatment, treatment procedures. You're able to filter through as well by, toggling in the different filter elements here by age, region, income, and racially marginalized groups. Next page. Here you'll find data and why some people are not accessing care and what actions they take when care is out of reach. So more information here about that. And then the last page explores awareness of dental regulation, including the RCDSO, perceptions of dental care, quality, fairness, and regulatory effectiveness. And this really concludes our presentation, and thank you for the opportunity to present. I'm really opening it up for a Q&A with the time that we have.
Thank you both, Doa and Jessica, for that presentation. At this point in time, I will look around to council to see if there are any people with questions or reflections on the presentation that we've just seen. Osama.
Thank you for that. That's a great presentation, very informative. I was just wondering if you guys had any, when they did this, when you had these patients do the surveys, did they put any comments in? And I kind of would like to see some of the comments around like the cleanliness component of things, because 81% seems high, but 19% seems also very high as well. And then, how can that fit into this more qualitative part of the collection as well?
Sure, I can take a crack. No, there wasn't an opportunity to provide more qualitative information within the survey, but definitely this is a place to be looking at an opportunity to where there'd be interest for deeper dives and understanding in a more qualitative context. For other studies that we've conducted, we've typically linked the survey as well with some qualitative data collection to contextualize on the information. So there is room to do that, to further contextualize on the information and humanize the statistics.
I guess the only other thing I'd like to add to that is that, this was a nice baseline to see where those scores are comparatively lower. So generally, when they go out, our clients will go out again. It gives them an opportunity to know, hey, when we get feedback, let's try to explore this a little bit more. And so sometimes questions are tailored to go into the survey to really explore those things of interest. But this as a first baseline kind of gives you a sense of where people are at, with, of course, the ability, in future iterations or in subsequent research to really dig into the why, what does that mean for folks.
Thank you. Judy.
Yes, thank you. Again, I echo Osama's comments. Very informative, interesting results. I'm just wondering if you could explain how you went about collecting this group of 2,000 people who were your respondents. I mean, sometimes when there's a self-selected group, the responses are a little bit skewed. So I'm just wondering how you did that.
Sure, happy to speak towards that. So right now we work with online panels that have large reach. So we're talking about, hundreds of thousands of people who have signed up to participate in research. It's really been a transition to move over to online panels from telephone surveying methodologies. While they're great to have that random digit dialing, we all know that people interact differently when it comes to phones. In many cases, they don't pick up. There's kind of that expectation that there will be, an incentive and compensation and all of those things. And so it's really standard practice in a lot of market research and public opinion research to source panels through, or to source data through panels, and the panel providers themselves, their whole job is managing applicants. We're refreshing the resources, making sure you're getting new perspectives. And then through the sampling approach, we put in soft quotas to reflect Statistics Canada demographic, markers to ensure that we're pulling a sample that is reflective overall. But that's typically the approach, or that's how that's handled typically, to try to get feedback on that level. It's kind of a cost effective as well as a way to kind of get the feedback in a way that, we see stable and consistent over time and is in line with best practice. Any other, I know there's a lot of hands up, but any more questions on that aspect?
Would you say that the selection process is randomized?
The selection process is randomized of the hundreds of thousands of individuals who recruit to the panel. So I guess that always becomes the key determining factor. Who is your panel provider? What sample do they have them? How are they sourcing them? Is it a systematic process? What data quality controls do they have in place to ensure that they're refreshing their panel? They're doing quality control if they think there are fraudulent responses. So it's quite an elaborate resource. But yes, it would be randomly sampled from those group of applicants.
So you're randomly selecting from self-selected applicants or
that's correct,
participants. Yeah. Okay, thank you.
Thank you. Ram?
Yeah, just a follow-up to Judy's question. Have you had any sample of Aboriginal communities or natives?
Yes, we do ask that as a sample size question. Do you identify as First Nations? And we do have a sample. I mean, of course, it's comparatively lower. Overall, it's proportionate to the overall sample. But again, at 2,000, it's a smaller number. So we do have some perspectives there. We do see that there are gaps in perception, but the sample size is low. What we found with some of our other clients who have done voice of patient over multiple years is that because they start to get more data of those smaller subpopulations that you want to understand in more depth, it gives you a larger sample size to be able to look at the data more holistically. We know that in panel data, when we usually go out annually, you get new respondents. So it's a refreshed respondent. So it's not the same folks each time. And so once you have more data, that can give you a bit more. But yes, we did talk to folks who identify as Indigenous.
Has there been any geographical distribution of those samples?
We did take a look at different geographic distributions as well, too. Unfortunately, with subgroups and the geographic distribution, it gets a little bit smaller on the sample sizes.
Okay, thank you.
Thank you. At this point in time, Doa, Jessica, Leslie, and Michelle, thank you so much for the work that you did in this area and for the presentation this afternoon. And thank you, Jessica and Doa, for your attendance this afternoon.
Thank you very much for having us.
Council, next item on the agenda is item number 11. It's designed to highlight college progress on the strategic plan. This item concerns access to care, one of the 6 strategic projects currently underway. You have received several updates on this project over the course of 2024. As you recall, there is a working group focused on this work. The group includes 4 council members, Dr. Aaron Walker, Dr. Noah Goma, Mr. Brian Smith, and Ms. Vivian Hu, as well as faculty representatives and subject matter experts. Dr. Carlos Quinones chairs the group, and it is supported by both a policy and clinical staff lead. At our December meeting, Michelle Gabrera-Gali walked us through an outline of a proposed approach to the professionalism guide. We had a good discussion about the core components of the guide. All of your feedback was provided to the working group. The materials in your package can be found from pages 186 to 201. Today, we will have an opportunity to discuss the draft version of the document to be posted for consultation. This item is for council's decision. And at this point in time, I'm going to turn it over to you, Dr. Walker, to walk council through the material. Erin?
Thank you. Good afternoon, everybody. I'm pleased to present the draft Foundations of Professionalism document on behalf of the working group. Before we get into the draft document, I'll provide some context. The draft Foundations of Professionalism document was developed as part of the Access to Care strategic project. This project has 4 areas of focus, and for the last half of this project, we're focusing on professional expectations and collaboration and engagement. Council directed that we develop professional expectations regarding professionalism and accepting new patients into dental practices. We are using the collaboration and engagement strategies noted in the circle on the right to help us develop these 2 new college documents. I want to highlight that there is a working group, as Hanno mentioned, comprised of council members, including myself, dental faculty representatives, and subject matter experts that has been providing direction on the contents of both documents. The document on professionalism sets out the principles and duties of the profession and will replace our existing code of ethics. This document will serve as a foundation for all of the college's standards and resources. The intention with this document is to reflect how dentists are currently practicing, that is, the high standard of professionalism they commit to and demonstrate throughout their careers. The new standard on accepting patients will set out the legal, professional, and ethical obligations of the profession. The key objectives for both documents are to ensure that the content reflects the college's public interest mandate, ensure that the documents contain guidance on the provision of culturally safe, inclusive, equitable, and accessible care, and ultimately increase access to care for patients in Ontario. The working group decided to develop the professionalism document first, as it is foundational in nature and will help inform the positions and the standards on accepting new patients. To help inform the development of the draft professionalism document, the working group considered the foundational research that has been conducted, along with feedback that has been obtained via various consultations and outreach strategies. This included a preliminary consultation that was held early last year and public polling that was conducted at the end of last year. Key findings from the polling results have been included in this briefing note, and you've also received information about public polling as a separate item that we've just seen. The working group is using the college's regular standards review and development process to develop the professionalism document. And you've heard about this process at previous meetings, but we've added an extra step in the process for this project so Council could preview the draft positions and content the working group was contemplating for the draft professionalism document, as we saw at the December 2024 Council meeting. The working group considered Council's feedback, which was very positive and supportive of the initial thinking and direction of the working group, and when we were fine-tuning the draft before you today. So you'll see that we're about halfway through the process. Now we're at the point where we're seeking Council's approval to consult on this draft document externally. Now let's turn to the draft Foundations of Professionalism document, which can be found in your materials on pages 194 to 201. As I mentioned, the draft Foundations of Professionalism document will replace the existing Code of Ethics. The intention is not to create new commitments and duties, but to simply reflect the existing commitments and duties that dentists have and demonstrate on an ongoing basis. The draft document is intended to help dentists navigate clinical and professional practice and the ethical complexities that are certain to arise, and is not intended to be prescriptive. As noted earlier, the document will serve as a foundation for all of the college's standards of practice documents and resources. The draft document is high level, but comprehensive in the sense that it covers all of the core principles and duties that dentists have. The standards and practice and other colleges' resources will set out the more specific requirements on issues or areas of practice, such as consent boundaries, record keeping, and different practices. This slide illustrates how the draft document is structured. The draft document has an introduction, which describes the components of professionalism as acting in the best interests of patients and society, and the duties dentists have as fiduciaries to their patients. The duties that dentists have to their patients under fiduciary law include things like acting in patients' best interests, avoiding conflicts of interest, and protecting patients' privacy and confidentiality. The working group felt it was important to emphasize dentists' responsibility to act in the best interest of patients and society because it aligns with the college's duty to serve and protect the public interest and what the public thinks is important. The working group wanted to include the key duties dentists have through fiduciary law because they are clear and relatable. The document then sets out principles and duties which reflect how dentists are currently practicing. This content is organized by the classic bioethical principles of patient autonomy, beneficence, non-maleficence, and justice. The working group used these principles because they're well known and accepted in healthcare and used by many other healthcare regulators. The working group also included a glossary as an appendix to the document to enhance clarity and facilitate understanding. The working group embedded these important concepts in the draft document. The working group acknowledged the importance of patient-centered and culturally safe care in dentistry and wanted to highlight this throughout the document. The working group also recognizes how important equity, diversity, and inclusion is to the college and incorporated these concepts throughout the document. You may not see specific EDI terms like cultural safety in the document, though. This is because EDI language is constantly changing, and the working group wanted this document to have longevity. The working group also included the existing duties dentists have. The working group wanted to ensure the document was comprehensive in the sense that it touched on what the key duties are without going into specifics. For example, the draft document notes that dentists have a legal duty to obtain consent for treatment and then directs readers to the standard of practice on consent to treatment for more information about what the specific requirements are. The draft document includes examples of how dentists can meet each principle. Again, these examples reflect what dentists are already doing in practice. I'll highlight a few of these examples for you now, along with the working group's rationale for including them in the draft document. So the draft document has a number of examples of how dentists can respect patient autonomy, including providing care that is responsive to patient needs, values, beliefs, goals, social identities, and economic circumstances. The working group included this example as it may help bring awareness to the social and economic factors that can impede a patient's ability to access dental care. It is also consistent with what the public feels is important. The draft document includes this example of how dentists can meet the principle of beneficence, or to do good. Again, the working group wanted to emphasize how important it is for dentists to act in the best interests of patients and society. The working group also wanted to include examples that speak to the individual and collective responsibilities dentists have to society more broadly. The draft document includes some examples of how dentists can meet the principle of non-maleficence, or to do no harm. This is one of the provisions that relates to addressing harm and misconduct. The working group wanted to encourage dentists to raise concerns about inappropriate, unprofessional, or otherwise concerning behaviors to help protect patients and society from harm. Some regulators also have a similar ethical requirement to raise concerns. The draft document includes a number of examples of how dentists can meet the principle of justice, or to be fair and equitable. The public thinks that dentists have a responsibility to ensure that care is fair and respectful for all. The working group wanted to reinforce dentists' legal obligations with respect to human rights, as this is a very technical and important area of law. The working group is also considering other ways to help dentists implement policies and practices that comply with human rights law, such as implementation of resources and continuing education. The working group acknowledged that many dentists are already volunteering in a variety of initiatives that support equitable access to healthcare, and did not feel that it was necessary to make participating in any specific initiative mandatory. In terms of next steps, if you approve the release of the draft document for external consultation, the consultation will be held this spring. The working group will then consider the consultation feedback and make revisions, and present that revised draft to you for final approval by the end of this year. The working group is continuing to develop the standard on accepting new patients, and that draft will come to you in the fourth quarter of this year for approval to consult externally. So that brings us to the questions before you today. 1, does Council have any feedback on the draft Foundations of Professionalism document? And 2, does Council approve the motion to release the draft Foundations of Professionalism document for external consultation? I'll hand it back over to Hanno to facilitate the discussion, and also here to help answer questions are Michelle Cabrero-Gali and Andrea Foti.
Thank you very much, Erin. Council, at this point in time, I will take a speaker's list if people have questions or comments to be made. Anthony Mayer.
Thank you, Hannah. I just have one brief comment, actually, which is found on page 197, line 124. reading it as a registrant who is not involved in the college, participating in the regulation of the profession, just, when you read the footnote, you understand what that line means, but I suspect that it'd be easier for the registrants if you just put the footnote in the actual line. Because it just seems a little jarring, especially if you're, what do you mean I have to participate, is what I think dentists are gonna, when they read that. So then they're gonna maybe not read the footnote because the type is too small. Thanks.
Thank you. I've made a note of that.
Thank you. Judy?
Yes, thank you. I just want to say, I think particularly when you're creating a first document, this is a really, really good document. It's really well-rounded. I just have a couple comments, and it relates to your definition of professionalism. And, you know, further up in this draft, when you're discussing, you know, what is sort of non-beneficence, things like that, you're giving examples. And I find that given that this is a document relating to professionalism, the definition of professionalism is a bit vague, and that it could stand to have some concrete examples, if nothing else, of what, you know, professionalism is, and sort of maybe even related back to the regulation on misconduct, professional misconduct, because the terms that are used in the definition are themselves somewhat vague and open to interpretation. Maybe that's your objective, but it seems to me that when this is replacing the code of conduct, it needs to be a little tighter.
Thank you. I think examples are a great idea, and I'll make note of that. As for where the definition came from, I'm going to put this back over to Michelle, because this is something we, as a committee, we actually spent probably close to 2 meetings looking.
I'm sure.
Looking at all the possible definitions and jurisdictions. So Michelle, did you want to provide a bit more background?
Sure. Thank you, Erin. And yes, so the definition here is from the literature. So we've modified it a bit, but we were inspired by a definition in the literature, and the authors were Cruz and Cruz. Yeah. So that's it.
Well, I just want to say that, you know, I understand relying on literature, but this is supposed to be a practical, practical hands-on type policy. It's not, you know, I can see where discipline proceedings might rely on this document, and some concrete examples, or maybe some more, the use of terms that are not quite so vague would be helpful if it's going to be used as a standard against which the conduct of dentists is measured.
I think we can take that feedback back to the working group, Judy. So thank you for that. And then I will just say that the more specifics of what it means to be professionalism, I think the working group really tried to articulate that throughout the whole document. So like through the principles and the duties that you see in the content. But we can certainly think about how to make the definition a bit clearer or more user-friendly and understandable. So thank you for that.
Thank you. At this point in time, I have no other speakers on my list, so if we could have motion number 4 on the screen, please. And Council, for your consideration, that Council approves the release of the draft Foundations of Professionalism as set out in Appendix A for external consultation, moved by Anthony Lisho, seconded by Iliad. All those in favor, please raise your virtual.
Can we have some, I've heard, before we do the vote, we had a couple of people, including myself, who made suggestions, and Erin's response was that the feedback would be taken into consideration. So, I mean, if you want to do a motion where it says subject to modifications based on feedback, that's one thing. But, I mean, my understanding was the document might be altered slightly from this.
Hanno, do you mind if it's Andrea, do you mind if I could just come in?
Please.
So I think there's a couple ways we could proceed. And one is we could modify the document now before it goes out to consultation. The other option is we can send it out for consultation, see what else we get back, and incorporate the feedback we've heard today into the next version, which you'll see. So I think it depends on, I guess, what your direction is to us.
Well, that's all I'm asking is for some clarity on that.
Sure. So probably what I would propose, if council's comfortable with it, is that we go out with the document as is. We've noted your feedback. We'll absolutely take that on board. The benefit being it will allow us to get out for consultation and keep the process moving, and also allow us to talk with the working group about your suggestions and run it past them. So if council's comfortable with that, that would be how I'd suggest we proceed. And then absolutely, they won't be lost. We've got it down. And when you see it again, you'll see those incorporated along with anything else we do through the consultation.
Okay, I don't have a problem with that. I'm fully supportive of that approach, but that's not, to me, that's not how the motion read to me, and so I just wanted some clarity.
Sure.
And maybe in future, when introducing motions, we could actually explain what the, where they are in the process and
Sure.
where that feedback will be incorporated before we vote.
Of course. Yeah, we
Okay.
can take that back,
All
Judy,
right.
and make that clearer for sure.
Thank you.
Thank you.
Okay, thank you. And Judy, you're okay with moving forward then? Okay, thank you. And I saw lots of heads nodding, so I think Andrea, council was sort of certainly in agreement with what you were saying. So if we could then just have motion number 4 back on the screen, please. And I believe the mover was Anthony, the second was Iliad, but I'll wait till it's on the screen. Oh, you've seen it already? Okay. So all those in favor, and that motion is carried. Thank you very much. Next item on the agenda, number 12, is one of 6 projects under the 2023-2025 strategic plan for the college, concerns the modernization of standards. As the policy team reviewed the standards of practice most urgently in need of review, one emerging issue that is not a standard was identified: artificial intelligence. AI has become a prominent issue in the dental care landscape, and AI tools are already being used in practice. AI is expected to be the subject of increasing inquiries to the college in the coming years and carries with it potential risk to patients. The decision was that it would not be the subject of a new standard of practice at this time, but in advance of a dedicated standard, it would be beneficial to develop guidance. Staff led a consultation in 2024 to ascertain the views of the profession on the use of AI. The material can be found in your package from pages 202 to 214, and this item is for council's decision. I'm now going to turn it over to Alex Wong, Senior Policy Analyst, to walk council through the next phase of this work. Alex, please.
Thank you, Hanno.
All right. Good afternoon, Council. Today I'll be providing an overview of artificial intelligence in dentistry and the draft guidance we've developed, which is before you today for approval to release for public consultation. I'll be happy to take your questions and feedback at the end. I'll start with some background on AI, what it is, some of its current uses in healthcare and dentistry, along with key challenges. One definition of AI, which we use in the draft guidance, refers to computer systems that can perform tasks commonly associated with human intelligence. These tasks can include things like pattern finding, problem solving, learning, and decision making. AI, generally speaking, is already integrated in a lot of the technology we may use today. So for example, in web searches, targeted advertising, translation tools, or virtual assistants like Siri or Alexa. You may have also encountered other terms when hearing about AI, and I'll just touch on a few concepts. Generative AI is a type of AI that creates new content based on patterns it has learned from its training data. Machine learning describes computers learning and improving their performance through recognizing patterns without being explicitly programmed. Large language models are models trained on huge amounts of text data and can understand and generate human-like language. Concerns about AI often relate to generative AI, in large part because of its novel and less predictable nature. A prime example of a tool which embodies these three kinds of AI is ChatGPT. ChatGPT has been considered a revolutionary tool because of how well it understands context and mimics natural conversation. And over time, it has become more refined through continuous learning. While these models can be as or even more accurate than humans in some cases, there are also risks of errors. And hallucinations is a term that's sometimes used for when information created by AI is inaccurate, false, or misleading. There are recent developments in the past year that illustrate some ways that AI can be used in dentistry. So in July 2024, Boston-based company Perceptive announced that it had completed the first fully automated dental procedure on a human. Using a dental robotic system that integrates AI-driven 3D imaging software with a robotic arm design, a crown replacement was completed in 15 minutes, a procedure that normally takes 2 one-hour appointments. This case highlights AI's potential for high precision and increased efficiency in dental procedures. Last spring, the Ontario government ran a pilot program for the use of AI scribes by primary care providers. Participants reported saving 3 to 4 hours per week on paperwork, freeing up time to spend on patient care. And along with the benefit of reduced administrative burden, participants reported improved documentation practices, increased job satisfaction and work-life balance, and perceived improvements in quality of care. There were some barriers identified, including lacking the appropriate hardware, such as microphones, a lack of institutional standards or guidelines for the use of AI, which delayed or prohibited its use, and the cost of the scribe license. Dental corporations are also partnering with AI companies, which will drive their adoption and implementation across Canada. The AI platforms being adopted help dentists read patient x-rays and identify a range of dental conditions such as caries, bone loss, and calculus. So along with these examples of AI I've just described, there are other uses to be found, including remote patient monitoring with AI tools, practice management tools, and AI virtual assistants. This publication from the World Health Organization spells out many of the major challenges we face as we think about AI, specifically in the field of healthcare. An understanding of these issues has helped inform the topics the draft guidance focuses on. For example, key issues of consent, privacy, and security are raised due to the vast amounts of data that AI uses for training. We're also alert to the concern that AI can potentially perpetuate bias based on its training data, for example, if it excludes certain demographics. The WHO guidance also recognizes that a balance must be struck between protecting the public and promoting growth and innovation, which our draft guidance aims to do. There are a growing number of regulatory bodies releasing guidance on AI in the past year. Several health regulatory colleges have published newsletters, articles, or FAQs about the topic. Many medical and legal regulators in Canada have released guidance on the use of AI. That said, no oral health regulators in Canada have yet released official guidance or policy, so RCDSO would be a leader in the area by developing guidance at this time. Which leads me to the discussion on the development of our draft guidance. Early last year, the policy team undertook a prioritization analysis, which involved a review of all existing standards and some emerging issues. AI was identified as an important emerging issue. This analysis was presented to the Quality Assurance Committee, and QAC approved the policy team's recommendations to develop draft guidance on AI. As we've seen, AI tools are beginning to be more widely adopted in the sector, but it's not just the growing use of AI that makes it an important topic to look at, but the fact that there is a lack of regulation in this space, which can pose risks to the public. This slide shows our standards review and development process, which we are bringing the draft guidance through. We've conducted a preliminary consultation on the topic and produced an initial draft for further consultation. Should Council approve the draft, it will be released to the public for consultation for a period of 60 days. And after consultation, the feedback will be reviewed and appropriate revisions made to the draft before it comes back for final approval. These are our approximate timelines. Once approved, we will consult till the end of May. Redrafting will follow in the summer, with finalization anticipated by fall, winter of this year. Now I want to highlight the different engagement activities we've conducted to date, which have helped inform the draft guidance. We've consulted with the public on the topic of AI through the preliminary consultation and the citizen advisory group. We've had several people review versions of the draft guidance, including our staff clinical leads, Drs. Vicky Nguyen and Kalyani Boldota, our standing policy working group, and external subject matter experts, Drs. Peter Fritz and Zubin Austin, and they've all provided helpful feedback to help us strengthen the guidance. The preliminary consultation took place last summer. A detailed summary report is linked in the briefing materials, but in brief, the consultation aimed to obtain the views of dentists, patients, and the public on the use of AI in dentistry. Among the findings were that a minority of dentist respondents stated they're currently using AI, but a majority anticipate adopting it within 5 years. Both benefits and risks were identified by respondents. Many identified AI as being a potentially useful tool for a range of administrative, operational, and clinical uses, but a common thread was that it should not replace a dentist's judgment or knowledge. Many also expressed concern about over-reliance on AI and the potential for overdiagnosis and inaccuracies. The Citizen Advisory Group consists of patients and caregivers who provide feedback to regulatory health colleges on topics related to standards and professionalism. We were one of 9 regulatory health colleges co-sponsoring a meeting with CAG on the topic of healthcare providers' use of AI last November. Participants highlighted the importance of transparency, having confidence in the validity of the tools and the privacy and security of their data, and they also strongly emphasized the importance of maintaining a personal connection with their healthcare provider when using AI. Regulating AI can involve various goals which can come up against each other. For instance, goals of certainty, flexibility, safety, and innovation. And as a regulator, the college has an overarching mandate to serve in the public interest. Because of these unique challenges in regulating AI right now, we've decided to take the path of drafting guidance rather than a standard of practice. And the differences between these I will explain shortly. I think it's also helpful to recognize that regulation of AI requires the collective efforts of many different parties. For example, the government can create laws that provide a framework for regulation. Government bodies can implement rules to ensure products that go to market are safe and effective. And AI developers have a large role to play in ensuring that their products are safe and effective. RCDSO is one player, and we also have different tools that we can use. Creating guidance may be a first step we take to help regulate AI. This chart summarizes key differences between the draft guidance and our existing standards of practice. Our standards are clearly defined and described in public-facing documents. On the other hand, this draft guidance is a new type of document. The key difference is that standards set out specific requirements based on established evidence and best practices. Our AI guidance provides advice or recommendations in an area that is emerging and new. It's intended to give us greater flexibility and help us adapt to the rapidly evolving nature of this area. Eventually, as best practices develop, this guidance could be updated into a standard. This approach is also generally in line with the approach taken by other Canadian regulators right now who have published advice to the profession or interim guidance documents. The draft guidance has been provided for your review, but I will just give a high-level summary of its content. It includes a preamble explaining the difference between guidance and a standard of practice, as I just spoke to. In addition, we have a definition of artificial intelligence, as stated at the beginning of the presentation. Principles which form the foundation of the guidance, such as dentists remaining responsible and accountable for their care, decision-making, and documentation. Existing requirements which can be found in our Code of Ethics, other standards of practice, and law that may be particularly relevant to the use of AI in dentistry. The draft guidance recognizes that there are a range of uses for AI in dentistry, but there may be differing levels of risk depending on the nature of the tool. The use of some tools may be considered lower risk, for example, those used for helping develop patient education materials or drafting letters. Where the use of AI may directly impact clinical decision-making and pose a risk of harm to patients, for instance, a clinical tool that informs a diagnosis or treatment plan, or if it directly involves the use of patients' health information, this calls for greater caution and oversight from dentists. The recommendations in this guidance can be categorized under 3 broad headings. Accountability and responsibility includes guidance around assessing the appropriateness of using AI, understanding the tools, and around reviewing outputs and ensuring care is appropriate to each patient's circumstances. Transparency and disclosure speaks to notifying and informing patients of the use of AI and accommodating their wishes. Protecting patient health information includes guidance speaking to understanding privacy and security settings. Now I'll open up the floor to council to provide any feedback or ask any questions. And the decision before you is whether you approve the draft guidance for public consultation. Thank you.
Thank you, Alex. Daniel Fortino.
Thank you, Alex. That was excellent. In regards to protecting patient health information, I think AI is obviously evolving quite rapidly. A lot of the AI softwares are becoming integrated into the dental software program. As a result of that, we are sort of unsure on where or how to protect patient care or information, because now it's sometimes they're a cloud-based program or whatnot, and do they have full access to the patient profile and patient records? How do we protect against that, and who actually has access to that information if we're using an AI software?
It's a good question. Privacy and security are obviously very important aspects of using AI. I think dentists and the draft guidance encourage dentists to do their due diligence before they choose an AI platform. So inquiring of manufacturers and also doing outside research of whether they are compliant. Whether they know their legal obligations in terms of privacy and security, asking them how they store their data, where it's stored, whether it's compliant with PHIPAA, those sorts of questions. I think dentists can also, there are resources in the draft guidance around privacy impact assessments. There's resources from the Privacy Commissioner. So all those are different aspects of making sure that due diligence is done. I think there's also the consideration perhaps of whether cybersecurity insurance is appropriate. So I think it's important. It's an important question for dentists, and it's important for them to stay up to date in terms of what those privacy best practices and resources are.
So would you encourage, if someone is using AI in their practice, to have 2 separate components or systems so that it's not integrated into their everyday software?
It's difficult for me to speak to the specifics, I think, of your practice, but I think it's a good question to ask, and maybe to do that assessment and maybe seek legal advice on that question.
Okay. Thank you.
If that's okay. Yeah. Thank you.
Thank you. Osama?
Thank you. Great presentation.
Thank you.
I have a couple of comments. First is just as an extension to what Daniel had said, because this is because it's emerging and it's so ever-changing. The risks are, it's hard to kind of pinpoint what they will be in 6 months, and so to try to create some guidelines without being too specific, it is very difficult. So I understand the challenge in that. I just wanted to bring one example up, and in the scribe, does so some of the software that's done for scribes right now is where you could walk into the room and then just talk to the patient, and then it'll write your note for you. So what's the legal document here? So that's a big, an emerging kind of, from a legal standpoint too, which one is the legal document? Is it the conversation, or is it the the recording, and how long does it have to be? So there's all these guidelines that are not necessarily out there right now. So There's a whole new world for that. The question that I kind of had was with regards to categorizing some of the technology. How often are we going to be revisiting that? Because as the technology gets better, it may become higher risk. And so I guess hopefully I asked that properly. Okay, yeah. So what are your thoughts on that?
Thanks for your question. I think a theme I'm hearing from your comments is that this is very fast-paced, a lot is happening, a lot is shifting, a lot is evolving, and I just want to point again to the fact that this is draft guidance is intended to help us be more responsive to those changes. And there is also the opportunity for us to develop a FAQ document that goes into some more detail around these more specific questions that we can update more frequently in order to answer those questions that dentists will be having and also update it as appropriate as things change. So I think it is yet to be seen how integrated these tools will become and what exactly these tools will look like. So we are anticipating that.
Thank you. Anthony Lisho?
Thank you. Great points by both Daniel and Osama, and responses as well. I think the perfect place right now, as we've been pointed out to, is guidelines. I think that's where it belongs for now because it's so ever changing. The RCDS is a perfect example of how important cybersecurity is. And unfortunately, dental offices haven't bought into it yet. Some have, but very, very few. And I think that's the next phase. Cybersecurity is going to have to be a very, very, very important aspect of a dental practice and its protocols. Because if you do anything on AI today, and then let's say it's out into the public domain right away, and who knows where it goes from there. So I think as a guideline, it's the perfect place to be because we can be flexible and we can get further into it and move as we have to as things develop. But certainly, I think the one thing that dental offices, dental practices should think about more closely is cybersecurity. Thank you.
Thanks, Anthony. Mark?
Thanks, Hanno. Alex, Cameron, thank you for a great piece of work. My reflections. When I listen to my colleagues on council and in my own professional space, as we enter the discussion point of AI and providing some guidance to the profession, the word that consistently I hear is risk and risk management, which begs the question whether a draft guideline in relation to the use of AI to the profession should have a subset or a chapter or any reference to risk management, including perhaps consideration that any individual practice that is entertaining the adoption of AI in their practice have in place at least consideration for a robust crisis management plan or a communications plan in anticipation that the possibility exists that through the use of AI, a situation arises that they have to manage and respond to. So my comment is, it's a great document. The only suggestion I offer is whether at a later date it should be supplemented with reference to risk management and what tools an individual might want to put in place concurrent with the adoption of AI in their respective practice. Thank you.
Thank you. Nizar?
Thanks, and I'll echo everyone's comments that that was a terrific presentation. I don't actually have a question, but perhaps a comment. Because this is a field I'm actually very familiar with, without trying to sound facetious or pedantic in any way, but AI is changing rapidly, but AI is here to stay. And there's nothing we're going to be able to do about it. I don't want to be alarmist. I don't want to suggest, a variety of different concerns, because I actually am on the side where I believe it's enormously going to be helpful to humanity at large, seeing the potential. So I find documents like this, which I actually helped contribute to, very, very helpful, because I think it only starts to test the waters to ensure that our members are aware of what's happening. When we offer advice about be cautious about, how you adopt AI or what's involved or where you store it, in all honesty, we're actually being a little tongue-in-cheek, because most people don't even know that AI is already incorporated in everything that we do. And we've been using it for 15 years, right? If anyone's used Google Maps, you've used AI. If anyone's been on a banking website, you've used AI. And so I say to council, far smarter people than all of us are trying to sort of get their hands around it, and it's just getting away from them. So it is something, I think the most sage advice I've heard in our discussion is, as we learn, we inform others. And so I think documents like this, the work that the Standards Working Group is doing, I think will be enormously helpful. But I would say, by virtue of the reach that this council has with people in the field, simply tell people, learn as much as you can and do it as fast as you can, and you'll only be 2 or 3 years behind. Because that's how rapidly, it's exponentially now growing. And then if anyone's, down, just go on ChatGPT. It is offering legal advice, it's offering psychological advice, social work advice. It's unbelievable, and you go next week and you ask it the same question and you'll get an even more comprehensive answer. So it's to me it's fascinating, to others it's daunting, and I think it's kind of between both. So.
Thank you. Thank you, Alex, and thank you, Cameron. Thank you, Council, for your input. At this point in time, if we could have motion number 5 on the screen, please. That Council approves the release of the draft guidance, Artificial Intelligence in Dentistry, as set out in Appendix A of the resources for external consultation. And that's moved by Mark, seconded by Neil. All those in favor, please raise your virtual hand. And that motion is carried. Thank you very much. It is 3 o'clock now. We're going to take a 15-minute break, and we will reconvene here at 3:15. Please turn off your cameras, please.
So that last one, same concept, the feedback given. You can start.
Okay. Welcome back, Jamie. Congratulations. Next item on the agenda, Council, is item number 14. This item is in regard to the college's work on standards of practice for the dental profession. The work on standards is part of the 2023 to 2025 strategic plan. Standards modernization represents one of the college's 6 strategic projects. This item concerns important updates to the college's professional guidance on boundary violations and sexual abuse. The materials for this item are at pages 219 to 236 of your meeting package. And just a reminder, Council, this is a public forum. If you are asking questions or raising concerns or making comments, please do not raise any specific cases that you are aware of. This is about the modernization of the policy in general. You may recall that Council received a briefing on the draft standard in September of 2024. With your approval, the draft standard was posted for consultation for 60 days. This item is for Council's decision, and we have Shivani Sharma, Senior Policy Analyst, to lead us through the material. And Shivani, I'm going to turn it over to you now, please.
Thank you. Good afternoon, Council. I am here today to provide you with a presentation about the draft standard before you for consideration for final approval, the prevention of boundary violations and sexual abuse. The presentation will share a background of the draft standard, an overview of consultation feedback received, and key revisions that were made to the standard in response to that feedback. I've also left some time for you to ask any questions at the end of the presentation about the draft standard. And finally, you will have a decision to make about whether this draft standard should be approved as the standard of practice of the RCDSO. By way of reminder, the policy team was reviewing a practice advisory that came into effect in 2017 as part of the standards prioritization process. After reviewing the practice advisory, given that new legislation had come into effect in 2018 that affected the content of the advisory alongside the seriousness of the subject matter, we decided to rank it as high priority, and QAC directed that a new standard be created. We created a new draft standard using our typical process for creating standards that is outlined on page 220 of your meeting materials. This slide provides you with the trajectory of the development of this standard. The standard has proceeded in an expedited fashion as there was no preliminary consultation. This was due to the seriousness of the subject matter and the urgency to have the material updated. We are now at the target mark at the end of the arrow. Since we last presented to you, the draft standard was released for public consultation. The draft standard has been revised based on consultation feedback, and those revisions were reviewed by the Standing Policy Working Group and QAC. Their feedback was incorporated, and now the draft is being brought forward toward you. This is an overview of the new draft standard. The areas that are in red are the new areas that broaden the standard's comprehensiveness. These are the areas that the RCDSO has not provided any written resources on in the past. I'm going to talk about the public consultation. As you may recall, the draft standard was approved by Council for external consultation on September 20th, 2024. The consultation was undertaken between October and December of last year. Case scenarios were also released for consultation alongside the draft standard. There were a total of 95 respondents that participated in the consultation survey. Of these respondents, 4 were the organizations that are noted on the screen. The law firm wished to remain anonymous. Majority of respondents were general dentists. We also had participation from the Citizens Advisory Group, which is a shared resource of Ontario's health regulatory colleges and brings patient and caregiver voices and perspectives to inform regulatory initiatives. We had a number of subject matter experts that participated in the consultation from a variety of areas that were relevant to the standard. This included investigations, those with experience in investigating sexual abuse cases, mental health experts, especially those who were experts in trauma and violence-informed care. Legal experts, we had both internal legal counsel as well as external legal counsel review the standard, and both from a prosecution and defense perspective. And we also had other regulatory colleges who had recently updated their content on boundary violations and sexual abuse participate in the consultation. We also received 3 written responses to our consultation via email from these 3 organizations. The feedback from these organizations is described on page 222 of the briefing note in your materials. They were generally supportive of the draft standard, and some suggestions to improve clarity of content or add new information were made. The overall feedback on the draft standard was very positive. A majority of respondents that answered this section found the draft standard to be clearly written, easy to understand, and comprehensive. The percentages that you're seeing over there reflect those who either selected strongly agree or somewhat agree. We also had very good feedback on the case scenarios. A majority of the respondents who answered questions pertaining to them stated that they were clearly written, easy to understand, and helpful. There was also encouragement to develop more in relation to dual relationships, trauma and violence-informed care, and gift giving and receiving. The consultation feedback summary is available on pages 221 to 222 of your briefing note. What I am about to do is highlight some of the qualitative feedback that we received, that we responded to through either a revision in the draft standard or through the creation of a question in the FAQ or a case scenario. Just to note that the FAQs and case scenarios will be available once the standard is posted to the website if you choose to approve the standard. We heard that we needed to clarify some content and simplify some terms. You will see in the draft standard that there have been some new footnotes that have been added and some revisions made to certain terms. We were also asked to add a new trauma and violence-informed care requirement. Some respondents suggested a requirement to capture effective communication, including dentists continually explaining the steps of a treatment to a patient. This was added to the draft standard. We also heard from some registrants, particularly that they wanted to know how to learn more about trauma and violence-informed care. They stated that For many dentists, this may be a new area and it may require some learning opportunities. We have added resources to our FAQ and are also in the process of exploring offering courses for CE credits in the near future. We also heard that there should be some advice in place for dentists who treat staff as patients. This was mentioned by internal and external legal counsel alongside the ODA and the CDPA, and we have devoted a section in the FAQ to address this. We also heard that there should be more information to guide registrant discretion. This was in relation to the newer sections that require registrants to use their judgment in making decisions, such as gift giving and receiving and dual relationships. We have added additional guidance to our FAQ to cover this. We also heard that it would be helpful for the RCDSO to either provide a sample policy on gift giving and receiving or provide content for a policy on gift giving and receiving. We have added guidelines in our FAQ to address this. We were also asked to create new case scenarios, especially in relation to the newer areas of the draft standard. We have added those to the case scenarios, so there's now a total of 8 case scenarios. And it was also requested for us to add a new mandatory reporting requirement. This came into effect last year in December, and it pertains to dentists needing to report personal support workers if they have reasonable grounds to believe that they have sexually abused a patient while providing care or services to them. I'm now going to walk you through the key revisions that were made to the draft standard, and these are set out on pages 223 to 224 of your briefing note. So the boundary violations definition has been simplified, and the trauma and violence-informed care definition has been rephrased to emphasize that it is an approach to providing care with the objective of not re-traumatizing patients. In terms of provision number 2, which is about respecting factors that inform patient boundaries, we have added in current or past medical conditions as factors that can inform patient boundaries. In terms of not making inappropriate comments, we removed oral health and hygiene, and this was an example of an area in which inappropriate comments can be made. And the reason that we removed it was based on feedback from the Standing Policy Working Group, and they felt that it may result in some confusion about appropriate comments that can be made with respect to this during the course of providing dental care, and they did not want dentists to feel inhibited in doing so. However, just for you to know, the examples were not meant to be exhaustive, and so inappropriate comments about oral health and hygiene will still be covered by this provision in the standard, and if a registrant were to make those inappropriate comments, they would be accountable under this provision. Sexual orientation and gender identity has been placed on different lines just to lessen the perception that one can be inferred by the other, and race has been added as a category about which inappropriate comments can be made. In terms of inappropriate disclosure, there was a footnote that was added to explain what that means. And for provision number 13 and 14, which is about managing relations with persons closely associated with patients, the language was clarified to make it clear that the relationship with a closely associated person that would be potentially problematic would be a personal one, and it is the dentist-patient relationship that would have to end if patient care would be undermined. For provision number 15, which is about trauma and violence-informed care, we changed the title to emphasize that it is an approach to care, and a new requirement was added to explain steps of treatment, for dentists to explain the steps of a treatment and involve a patient to be an active participant in their care. There is also a new clarification about a patient who wears a bib or drape in the sense that while we have a requirement that dentists are not allowed to place any instruments or materials on a patient's body, that continues to be the case even if a patient does wear a bib or a drape. For provision number 21, this was changed to make it clear that the jokes that would be inappropriate to make are those with a sexual connotation. And for provision number 23, we added the new mandatory reporting requirement pertaining to PSWs that I explained earlier. So all of that led to the revised standard of practice that is before you, and this is just a preview on the screen of what it will look like in the event that you choose to approve it today. I'm just going to walk through very quickly and do a comparison of what has changed from the current practice advisory to the new draft standard. At a very high level, the new draft standard is much more comprehensive, and there are new topics that have been introduced. The definitions have been expanded to include new terms pertaining to those new areas. The principal section is now in numbered format. It also contains stronger language conveying the college's zero tolerance for sexual abuse. The maintaining boundaries part has been expanded to include the new areas that are addressed, and other examples of boundary violations relating to things like prohibited communication and other forms of abuse and harassment have been added. The part relating to preventing sexual abuse provides more examples of the less obvious cases of sexual abuse and also prohibits grooming behavior. The mandatory reporting requirement section has been expanded to include the new requirement pertaining to PSWs, and the record-keeping requirement section has also been expanded. Just to note that the case scenarios were updated to include 4 new ones associated with gift giving and receiving dual relationships, being in a personal relationship with a person closely associated with the patient, and trauma and violence-informed care. And we've also developed an FAQ to accompany the standard, and that responds to a lot of the qualitative feedback that was described earlier. You can find a summary of the FAQ content on page 225 of your meeting materials. In the future, we will also be creating a patient-centered resource, which will assist patients in understanding what to expect from their dentist and maintaining appropriate professional boundaries. So my question for you, there are 2 that you have to answer, but my first one is whether you have any feedback on the revised draft standard. I'm going to stop sharing my screen.
Neil.
Thank you, Shivani. You know what? It's an impressive document that you guys put together in such a short period of time. So excellent work on that. I don't know if it's intentionally been left out or if it should be included. A question that comes up with a lot of providers is not the inappropriate, but the accidental violation of potential personal space. The accidental brushing up against a patient's chest in treatment. Is there any protocol for that documentation? It's a question that comes up a lot, and I don't know if it's something that needs to be addressed in this document or how to handle it, if that makes any sense.
Thank you for your question. I will say that based on the regulatory scan that I conducted, that is not something that I saw as part of a standard on boundary violations and sexual abuse. It is perhaps something that we can address by way of an FAQ if it feels like it's something that needs to be addressed and something needs to be said about it, but it's not standard to include it in a document like this.
Thank you. Peter Deline.
Hello. I just wanted to point out line 85. Wasn't sure if there was a typo there. There are 3 words. It says dentists treats patients. I wasn't sure which word had the S too many, but one of them does. Thanks.
The way that it reads on my computer is using this approach, dentists treat patients. The S is crossed out. So I'm not seeing an error over there.
Yeah, I don't have it in front of me, so I just made a note reading it. Thanks.
Thank you.
So I have no more speakers on my list. Do you want me to pull up the motion now?
Yes, go ahead.
So if we could have motion number 7 on the screen, please.
Could I just make a comment before?
Yes.
Yeah, I wanted to say that this is a really difficult document to write, and I mean, there's always room for improvement, and as somebody who sits on the discipline committee, I read it from through that lens. But I just wanted to say that it's a really good document, and I commend you all for your work. And I also wanted to say that like every one of the presentations today has been a really good document being proposed, and that there's been a lot of work going on at the staff level. And I just want to commend everybody who's here as a council member, because we all appreciate how much is going on. So thank you.
Thank you so much for saying that. I really appreciate it.
Thank you for those comments, Judy. So if I could have motion number 7 on the screen, please. That council approves the revised draft standard of practice, prevention of boundary violations and sexual abuse as a standard of practice of the RCDSO. That's moved by Ram, seconded by Judy. All those in favor, please raise your virtual hand. And that motion has carried. Thank you. Our next item continues the work on standards as in the strategic plan. This item concerns the standard of practice on consent of treatment, or of consent to treatment. Many of you will recall that we reviewed the standard at our September council and approved it to be sent out for consultation. The material in your package can be found from pages 237 to 252. This item is for council's decision, and Cameron Thompson, Manager, Standards and Strategy, will walk council through this material. Cameron, I'm going to turn it over to you now, please.
Yeah, thanks, Hanno. Okay. I'm mindful that you heard a lot from the policy team today, but I hope you have stamina for one more item. So as you've heard, this item before you is for decision. It concerns the revised draft standard of practice consent to treatment. We're asking for your feedback on the draft standard and whether you approve it as a final standard of the college. And in the interest of time, I'm going to do my best to avoid repeating much of what's in the briefing note. I'll focus instead on sort of the essential details so that we have time for questions and discussion at the end. So before jumping into the draft, I just want to take a minute to locate everything within the content. So the requirements governing consent to treatment, so the obligations that apply to dentists and other healthcare providers arise from overlapping areas of ethics, law, and regulation. The key piece of legislation, as many of you likely know, governing consent to treatment is the Healthcare Consent Act, which sets out the rules for obtaining consent to treatment. And our practice guidance is largely a reflection of the legislation. And this draft standard really sits within these overlapping areas. For most dentists, the standard of practice is probably their main entry point for understanding their obligations for obtaining consent to treatment. And the most fundamental principle of consent is this idea up on the screen, that treatment cannot be provided without consent. Of course, there are always a handful of limited exceptions. And as you can see from the slide, the definition of treatment, which is set out in the legislation, is very broad. But besides the obvious importance of complying with legislation and RCDSO guidance, I think it's helpful to ask why consent is important. So what are the fundamental moral and ethical principles that underpin it? I think these are helpful to highlight as they inform the draft standard as well. At its core, the requirements for obtaining consent to treatment reflect the moral and legal right of each patient to make their own decisions regarding what treatment they will or will not accept. And this is a reflection of every patient's fundamental right to bodily autonomy. And there are potential consequences, as noted on the slide here, for healthcare providers, both legal and regulatory, where they fail to meet the requirements for obtaining consent. Which brings us to our current guidance, so the guidance that's currently in effect on the RCDSO website. Just by way of reminder, our current practice advisory on consent is one of the college's older documents. It's important to know that it does not attempt to provide a comprehensive overview of dentists' obligations for obtaining consent to treatment. It's more narrowly focused on obtaining consent from minors and incapable patients. And as many of you have heard, this practice advisory was reviewed by the policy team as part of our prioritization work, and it was approved by QAC as a high priority review last year. This slide represents the steps in our standards review and development process. You've now seen this image a few times over the course of today. The review and development of the consent standard really began immediately after QAC's approval last January. So this included, as is the case for all of our reviews, research analysis and preliminary drafting. The new updated draft standard was finalized last summer, and it was presented to Quality Assurance Committee and Council for feedback in August of last year. And for those of you who were at the September 2024 meeting of Council, you might remember that I presented the new draft consent to treatment standard for feedback and for approval to consult. And if you saw that little animation in the bottom right-hand side of the slide, this is the area that will be the focus of the remainder of my presentation. So these are the developments that have taken place since Council's approval to consult last September. And I'll start with an overview of the consultation. So the consultation that we undertook followed our usual stakeholder consultation process. You can find a detailed description of that process in the briefing note. There's also a very detailed consultation summary, which is linked in the briefing note, if you're interested to see sort of more specific details about the feedback. Very briefly, as you've been hearing, we invite feedback from a broad range of stakeholders, including all of RCDSO's registrants and key system partners, patient and advocacy groups, government agencies, and others. We use a number of communication strategies to do our best to reach the broadest possible audience. And the consultation, which was run mostly via an online survey, was open for 60 days. And this slide sets out some of the consultation results at a high level. So we received a total of 99 responses. This included 95 online surveys and 4 submissions, which we received via email. And just for context, based on our experience to date, this is a pretty typical rate of response. Looking at the survey feedback, as is usually the case, the majority was received from dentists. Around 93% of respondents self-identified as dentists. We also heard from 4 organizations, and they're represented up on the screen: the Ontario Dental Association, the CDPA, the College of Nurses of Ontario, and the College of Massage Therapists of Ontario. We always ask consultation participants a combination of general and targeted questions to assess both respondents' overall opinions of the draft, but also to prompt some specific feedback on key areas of interest. I think it's helpful to highlight the overall impressions of the draft standard in this case, which were quite positive. So on this slide, we're reporting overall positivity. So the percentages that are reported there are a combination of respondents who reported that they either strongly agreed or somewhat agreed with the question that was posed. And overall, you can see that respondents largely felt that the draft was accurate, comprehensive, easy to understand, and clearly written. We did also receive some constructive feedback, which is very helpful. You can see the key themes reflected here on the slide. And we were able to make a number of adjustments to the draft standard to reflect that feedback. So in particular, a number of respondents provided feedback around softening the tone of the draft to make it a little sort of friendlier to the reader. For instance, by removing some of the references to the potential for professional misconduct. There were several questions around the topic of assigning the consent conversation to a staff member or someone other than the dentist, what's sometimes sort of colloquially referred to as delegating that conversation. So there were a number of questions from respondents about that particular issue. And a significant number of respondents, probably a majority of respondents, commented on the section of the draft standard that set out advice for recording details in the patient record about the consent discussion, which they felt was a little bit onerous. I also want to emphasize sources of feedback beyond the respondents to the public consultation. So we received really helpful feedback from RCDSO staff dentists on the consultation draft. Both the Standing Policy Working Group and Quality Assurance Committee have reviewed the consultation feedback and proposed revisions, which are reflected in your materials. My main message here being that there have been a lot of eyes on the draft standard. We've received a lot of really helpful feedback along the way. Which brings us to the revised draft standard, which is before you for decision. You can find it as an appendix to the briefing note in your materials. The revised draft, as I've been saying, reflects the feedback that we've received since Council approved the draft for consultation last September. Overall, the revisions are relatively minor, though. So in terms of what's new or changed in the draft, so both between the current practice advisory and the draft standard, and between the consultation draft and the revised draft in your materials, the fundamental requirements for dentists obtaining consent to treatment have not changed. I think that's a really critical message. Overall, the changes are principally about reformatting content for clarity, ensuring accuracy, and the content has been expanded fairly significantly throughout. This slide reflects some of what I'm touching on here. So it reflects the key changes between the current practice advisory and the draft standard. As you can see, the draft, which is on the right side of this table, significantly expands the content that's addressed in the current practice advisory. And it now comprehensively captures all of dentists' key duties and obligations, including all the requirements set out in legislation. So no major new obligations have been added to this draft standard that did not already apply to dentists, but these are now reflected more in their entirety throughout the draft. This slide highlights only the key revisions that have been made since the consultation. So these are the changes in response to consultation feedback. They include general copy editing throughout the draft standard to correct typos, errors, and to ensure clarity. As noted in the briefing materials, we've adjusted some terminology. For instance, we're no longer referring to valid consent, as that terminology seemed to be a source of confusion. As I noted a moment ago, there was some confusion about the permissibility of dentists relying on someone else to engage in the consent discussion on their behalf. To permit a more fulsome sort of elaboration on this topic, we proposed transitioning that content into the FAQ that will accompany the standard should it be approved by council. And we've significantly modified and simplified our advice around the documentation of consent. And as noted, there are a number of supplementary resources that we've developed to support the release of the standard. So these include a new consented treatment infographic, which can act as a kind of chairside reference. And with the support of the college's practice advisors, we've also developed a series of FAQs on this topic. And some of the topics that are covered in those FAQs are reflected up on the screen. They include assistance to dentists in understanding the requirements for communicating material risks, which I know is often a source of confusion, advice around providing care to minors with divorced or separated parents, delegation of the consent discussion, as I mentioned, and creating consent forms. So these were the key topics of interest that we drew from the consultation feedback, and they reflect some of the common inquiries that come into to our practice advisory service. But just as a reminder, these are supplementary resources that accompany the standard. They're not subject to council approval in the same way that the standard is, and the benefit of that approach is it allows us to modify and update these FAQs on an ongoing basis in response to how the FAQs are received by our stakeholders, but also as new issues sort of come to light. Which brings us to the end of my presentation and the two key questions before you today, which is firstly, do you have any feedback or comments on the revised draft standard? And then secondly, do you approve the revised draft standard as a standard of practice of RCDSO? So I'll stop sharing my screen and happy to answer questions if there are any.
Thank you very much, Cameron. Are there any questions or comments for the presentation that we just heard? Okay. Thank you. Seeing none. Oh, Brian Smith. Okay. So in that case, if I could have motion number 8 on the screen, please. That council approves the revised draft standard of practice consent to treatment as a standard of practice of the RCDSO. That was moved by Brian Smith, seconded by Anthony Lisho. All those in favor, please raise your
Mr. Chairman, just before you have the motion, because it uses the word draft standard, it could actually be confused that this is not the final standard. I think the draft is a reference to what the document is marked. But this is we're approving a standard of practice for consent to treatment. So could I suggest that we delete the word draft and say as presented?
I agree.
So that council approves?
The standard of, the council approves the revised standard of practice, quote, consent to treatment as a standard of practice of the RCDSO, comma, as presented.
Okay, I'm seeing nods, so I'm thinking that's a friendly amendment. So thank you very much for that. So that wording, but as
presented.
As presented, thank you.
And take out the draft. Right?
Okay, thank you. And there was nodding around there, so if I could have, okay. Those in favor of that motion as amended, please raise your hand, your virtual hand. And that motion is carried. Thank you very much, Council. Thank you very much, Cameron, to you and your group and to your presentation. Next item on the agenda is other business. There was nothing that happened.
Just putting my hand up for the queue.
Oh, there's nothing that happened that we need to park in the parking lot, but I would like to take a moment just to look around to see if there is anyone who has a question or an issue to raise. And there are still a few virtual hands up, so I don't know if those are remnants of hands up or people who do wish to speak. Mr. Sandhu, I'm going to turn it over to you. You wish to speak? Okay.
I just want to take this opportunity to acknowledge the depth of work which we saw today, which has been done over the last 2-3 months, and the commitment of this council and the dedication of the staff. It is truly transformative. And I thank you, all of you, for your participation. And if we carry on like this over the next 2 years, I think we're going to totally transform this organization. Thank you.
Thank you, Harinder. Dan, I'm going to turn over to you now, please.
Yeah, thank you very much, Harinder, for saying that. And I also want to publicly acknowledge and express my appreciation for the team and the broader team. So you see the incredible group of people at the end of the room. What you heard today were the product of work, lots of work that was presented just so professionally. And our job is to make sure that you can do your job. Our job is to provide those inputs. And I think this group, not just here, but this group here, and you saw some new faces today and heard from some new individuals as well, is really trying to set the bar high for doing that. And I referred earlier this morning to our staff survey where about 90% of the staff said that they felt they could connect their role to the organizational goals and the strategic direction of the college. That's not only true with the group here, but it's true. We had a number of people watching from the college because this work that you did today and the decisions that you make, it directly impacts their work. It's applied in the various regulatory programs. It's communicated by staff to the profession and the public through our practice advisory service and other ways that we interact. So again, I just want to express my appreciation to this incredible group that's really helped you to fulfill your role today. So thank you.
Thank you. At this point in time, I would also like to take the opportunity to thank Council for your engaged participation today. I think there was an extensive speakers list, so hopefully everyone feels that we had a robust conversation and had the opportunity to participate. I would like to echo Harinder and Dan's comments on behalf of Council. Also a huge shout out to staff, those who are present here today, but also those people who are supporting us virtually. The reality is none of this could happen without you. So thank you again for all of that. A reminder that our next council meeting will be a virtual meeting and it will take place on Thursday, June 19th. So with that, we've come to the end of our agenda. The last item on the agenda is a motion to adjourn today's meeting. And that is moved by Mark, seconded by Daniel Haas. All those in favor, raise your virtual hand. Thank you. That motion is passed. We are adjourned. Have a great day.